Dr. Chandak sir, along with Dr. Vikas Jain sir, to join us for our first session of the day on stage.
Thank you, sir. Good afternoon to all dignitaries, guests, and delegates. Myself, Shama Shinu from Melville Academy, and we would be starting our sessions for the day. So let's begin with our first session on proximal humerus fractures, led by Chairman Dr. Asim Negi, sir, Co-Chair Dr. Vikas Jain, sir, and Director Dr. Chandak, sir. And the panelists for the sessions would be our patron, Dr. D.D. Tanna, sir, Chairman Dr. Asim Negi sir, Dr. Vikas Jain sir, Dr. Manoj Nagar sir, Dr. Nitin sir, Dr. Arun Lal KP sir, Dr. R.N. Chandak sir, and Dr. K.N. Subramaniam sir. Now we would like to invite Dr. Asim Negi sir on the stage to put a light on the session proximal humerus fractures.
Friends, welcome you all for this meeting. The conventional wisdom about treating proximal humerus fracture has been that almost 70 to 80% of these fractures can be treated conservatively. But after the advent of PILOS, today probably we are operating far more than this. That while treating proximal humerus fracture, decision making is most important, and that involves assessing the patient's physiological age, his activity level, bone quality, assessing the fracture usually by CT scan in 3 and 4 part fractures, and matching all this with goals and expectations of the patient, which will be different for a housewife, a lazy potato couch, and a cricket player. There is no controversy that high energy fractures in young patient, as shown on your right side, open fractures, fracture dislocations, fractures in high demand individuals, displaced and unstable patterns with good bone quality, they all require open reduction and internal fixation, and we should try our best to preserve the humeral head and restore the function. This 26-year-old male with a fresh fracture after an RTA, he is a chemical engineer, he came like this. You can see that there is a head split, there is a fracture in the glenoid also, the head is dislocated, and there is a lot of metaphyseal comminution in that area. We operated this patient with a deltopectoral approach. The subscap has been tagged with epibond sutures. You can see the deltoid being retracted. GT has been tagged again, so are the infraspinatus. Now, you can see that the glenoid fracture is far more displaced than what it was seen on CT because of the positioning probably, is getting reduced, and now is reduced, and it has been fixed with 2 interphrag screws. Then head is back in its position. Head split has been fixed with 3 headless compression screws. Then you just adjust the height of the plate. It should be 8 millimeters below the top of the articular surface. There you correct the varus of the head fragment, align this medial part of the head to medial shaft, and then you check your sagittal alignment on the lateral view. The plate should be center in the proximal as well as the lateral view, and he is here immediate post-op, then 6 weeks. 6 months, I asked him to get a bone grafting done, but the fellow refused and disappeared. He came back at 18 months. Fracture has nicely healed, and that's his function. And here, can you play the video? Yeah. good enough for almost 3/4 of the fractures in elderly, especially those who are above 70 years. They have got minimally displaced fractures, low energy trauma with osteoporotic bones. They are low demand patients and often have comorbidities like diabetes or coronary artery disease. This 64-year-old male, who is father of an orthopedic professor, had 15 years of diabetes, hypertension, and this type of fracture. Quite a few orthopods offered him surgery, but finally he was treated conservatively. This is how he is 6 months, and this is now almost 15 years. You can see his function. He is absolutely normal. He is now 79-year, very active male. My conservative treatment is shoulder immobilizer for about 3 to 4 weeks. Weekly x-rays are taken for first 3 weeks. You start passive mobilization at 3 weeks. You start active and assisted movements at 6 weeks and standing exercises of 3 months. You need a patient who is willing to convert to surgery if x-rays are not okay at any stage of treatment. You must be wondering then, what is the controversy? My plea is that fix all displaced fractures in young healthy patients and physiologically young and active seniors. The key words are displaced and young. However, they are subjective terms and require lot of judgment. What is displaced and what is young? This 55-year-old lady, busy radiologist, had this fracture to her dominant hand. This is her CT scan. There is a separate fragment of the greater tuberosity, but it's not in pretty bad position. It's more or less minimally displaced, and these are her x-rays. 1 week, 2 weeks post-injury. This 2 weeks post-injury x-ray, there was some panic. Look, this is getting now displaced. We must offer her surgery. We chose not to operate 5 weeks, and 6 months down the line, here she's doing yoga and all sorts of athletic activities. She has got absolutely normal function. No limitation, no pain, and full recovery of it. While treating these fractures by open reduction, the workhorse approach, however, is deltopactolol, but split deltoid or anterolateral is becoming more and more popular. While treating these fractures, you should know your implant because each company can have different configuration of the screws. If you are using nails, please use second generation nail which have got a medial entry point and do not traumatize the cuff, and make your best effort to avoid the implant related complications. The fracture of the greater tuberosity, isolated fracture, happens more often in the young patients after high velocity injury. Half of these form about 20% of the proximal humeral fractures. 90% can be treated conservatively, but those which go for surgery, you ought to use split deltoid. So that's the approach which you should familiarize yourself nicely. Those 90% which can be treated conservatively, you should immobilize in abduction and external rotation for 1 month. Weekly x-rays for secondary displacement. MRI should be done at 3 months if there is pain or loss of function. This 60-year-old male, obese, diabetic, asthmatic, that's his x-ray. It's not in perfect position, but comorbidities and other thing we chose to conserve him. 4 weeks, 8 weeks, and here he is with full recovery of function. While treating isolated GT fracture, you should be aware of late displacement. 60% of the minimally displaced fracture GT, they further displace at a follow-up. And patients who are young, especially male, they are higher risk of secondary displacement. 55 out of the patients, when followed, 20% had late GT migration. And this risk is 6 times more in patients below 70 years of age. Here is a patient with displaced greater tuberosity, treated by split deltoid. We have used a distal humeral distal radius plate for fixing this. Even 3 and 4 part fractures of the proximal humerus you can also treat by split deltoid. 45-year-old female, fresh fracture, split deltoid approach. You need the axillary nerve is about 6.5 millimeter from the acromion. You just identify the axillary nerve, never ever put a loop around it. This is my head end. I have traced the nerve there. You make a tunnel beneath that nerve with the help of a periosteum. If you abduct the arm, there is a lot of space there, and use Ethibond sutures to take all your tuberosities. Here you can pull the tuberosity to close this gap. You can maneuver the abduct or adduct the arm to reduce, use K-wires to reduce the fracture, and these K-wires are placed such that they don't interfere with further placement of the plate. Now you have reduced the fracture very well, and here comes the plate beneath the axillary nerve. We are adjusting the height of the plate. Here you can see it that K-wire is fixing it at the right place, and now this cortical screw is pulling the shaft laterally. This step you have to do under image intensifier so that you restore this Shenton line. Don't overdo this step, otherwise you will lose this contact here. And this is my final suture construct, and here is the patient at almost 9 months, full recovery of function. This is a good paper from Gavaskar, Philos for complex femoral PHF in elderly patients. They advise 7 locking head screws with 2 calcar screws, fixation augmented with traction cuff sutures, subchondral metaphyseal void packed with allograft or calcium phosphate cement, and if there is comminution of the medial calcar, they advocate endosteal fibular strut as and when required. This is an innovative way of fixing these fractures. Dr. Chandak has got a publication on this, all percutaneous 3-part fracture treated with the help of very economically priced K-wires, J-nail technique, and you can see that the fracture has gone on to heal anatomically. Patient is pretty old, yet he has got a full recovery of function. There is no varus, please note that. Philos has got its own share of complications. Impingement adhesions can occur. Avascular necrosis is because of the nature of the fracture, however, it's not disabling as it happens in the hip. But what's to be noted is that 1 out of 4 patients can end up in a reoperation. And this risk is 3.3 times higher in patients with more than 70 years of age. It's 1.6 times higher if patient is 60 years or plus. And screw penetration is the most common complication. 14% primary screw penetration and 8% secondary screw penetration. So please keep your screw length at least 8 millimeters short of the articular cartilage. This 70-year male patient with 4-part fracture dislocation, there is absolutely no point in even trying to fix it. He goes for an RSA. In a RCT at 2 years, the RSA reverse shoulder had a better outcome, far better outcome than those which were open reduced and internally fixed. So in today's conditions, indications for a reverse will be a 60-65 plus patient having a 3-4 part fracture or a dislocation and a very thin fragment. Indications for hemiarthroplasty have shrunken. They are very limited. Younger patient, 40, 45, you start with the idea of doing an open reduction. There is extreme risk of AVN. You are not able to fix it properly. You should always have a backup hemi on the table. The key to success is using correct version and height of the hemi there and trying to achieve anatomical healing in good position. That is my treatment algorithm for 2-part and 3-part dislocations. Lots of them can still be treated conservatively. Hemi has got a very limited scope, and patients above 65 complex fractures mostly should be treated by RSA. In India, it's not uncommon to get late cases. 29-year-old male, electric shock history, treated by physio, then by orthopods, poor quality films, overexposed, only AP view taken. 8 weeks down the line, shoulder having hardly any range and painful, and that's his CT and MRI, which shows that there is a large LT fragment and the head is stuck up behind the glenoid. We treated him by a deltopectoral, pried open the malunited LT, removing all soft callus there, mobilized it. Now my periosteum has dissected between the posterior border of the my periosteum has dissected between the posterior border of the glenoid, and I have brought the head from behind the glenoid on the lateral side. Using cob as a lever, gently push the head out and then down. As we are doing it, it goes distally also. This step, take your own time, don't rush it. You may injure the vessels there. Cob is on the posterior surface of the glenoid. Head is being pushed laterally and inferiorly, and this retractor pushes the head out. And then abduction and external rotation of the arm reduces the head opposite the glenoid. Now the head is sitting in the glenoid there, and check your final reduction. And finally, we have used anchor sutures to fix the LT. And here is my patient at 3 months post-op. Full recovery of function. So these are complex fractures. Do your homework well, and my suggestion is that you should be familiar with all the techniques. You can't just go with the idea that I am going to use percutaneous fixation or I am going to use a Philos. You should have a backup of hemi at least on the table, and you should know how to do a good hemi if you can't fix the fracture properly. Thank you very much.
Thank you, Dr. Negi, for setting up the tone and for giving us the algorithm for management of proximal humerus fracture. With this, we go ahead with the next case presentation, proximal humerus fracture management by Dr. Manoj Nagar. May I invite Dr. Nagar, please? By the time presentation is loaded up, any questions from the audience? For Dr. Negi, any question, any doubt or any comment you would like to make?
Those who are sitting behind, they can come forward, then it will be a better communication.
Good afternoon, Negi sir.
Yes, sir.
A very good presentation. Sorry, I will थोड़ा सा तंग करता हूँ. So what is, there are all anatomical plates in our body, they are of a same size everywhere. But as we give more and more importance of these Calcar screws, you have a single Philos plate for you, for me, for a 4.5 feet lady, for a 7 feet man. Most of the times in small females, the Calcar screws, they do not go in the Calcar, they go below it. If you try to put the plate up, it causes impingement. What's your bailout option in such situations?
Look, reduction is the paramount thing. So I won't bother about the Calcar screw. If it's possible, it's fine. Otherwise, I'm willing to live without that. But there shouldn't be any varas. One, your plate ought to be, top of the plate should be 8 millimeter below the top of the head. That is not negotiable. And most important on the lateral view, your sagittal alignment of the reduction as well as the plate placement. Sometimes the reduction is good, but the plate is oblique, either proximally or then you won't get screws in all the quadrants of the head. So reduction, height of the plate, and APN sagittal alignment. I will care more about. And however non-comminuted, or you may think that is two-part or is okay, but always, even GT fracture nicely big chunk fixed with good plate, 4 screws, 5 screws. I will always take sutures. If possible, fiber wire sutures, otherwise Ethibond is good enough. So,
Would you like to give an answer to that, or what you thought about it?
Ideally, exact answer I don't have, but in such situations where I I'm very much want to put that Calcar screws. I put 2.7 cortical screws with a bent drill bit. You drill with the drill bit, it gets its way just beneath the Calcar, and you put 2.7. The 3.5 are stiff. The 2.5 screws, they are a bit pliable. They find their way and end up in the Calcar. I do it sometimes.
Yes, Dr. Agrawal, you wanted to suggest?
Just we are sitting in the Merrill Academy. So can we have kind of a Asian phylos or mini phylos or anatomical plates based on our sizes?
So as for distal and radius, plates are available in low profile
Yes.
and in normal profile. So you would recommend Merrill to have a normal profile plate and a low profile plate. I think that's a wonderful suggestion.
Yeah.
And I think with this, we go ahead with the next presentation. We'll take up further questions later on. We'll go ahead with Dr. Nagar is ready. Yeah, please go ahead.
Good afternoon, chairpersons and faculties and delegates. I'm just going to show a case. It was one of my own case, and it was seemingly simple fracture which failed, and I learned a lot while I was treating this patient. So it was an early failure of a proximal humerus fracture fixation. So this was a patient who was an elderly female, short-heighted, obese, and she had a proximal humerus fracture in a dominant arm. She was hypertensive and bit obese. So that was the fracture. So it was, if you classify as per needs, it was bit distal, but you can say it was a two-part fracture, or you can even argue that it wasn't that much displaced. So it could very well have been managed conservatively, and it could have been managed operatively as well. I decided at that time, many years ago, to go forward and fix it. So the reason I decided to fix it, I thought that it's a dominant arm, it's an unstable fracture pattern, I'm going to mobilize early, and those were my early days, and I thought I can fix it. It was a simple fracture, so I decided to fix it. So as I said, the injury was in dominant arm. It was an unstable fracture pattern, especially rotatory unstable, and fixation would have allowed early mobilization, and I thought I could fix it. It was an easy fixation. So I decided to do a PHILOS, a proximal humerus locking plate, and use a deltopectoral approach. And I decided to use an interfrag screw if possible. So that's the fixation. I don't have very good post-op X-rays. So I tried to put interfrag screws, but because the fracture configuration was such that it was really difficult to go very medial because of the vascular structures medially. So probably I made some compromise in putting screws in whichever direction I could do. But I thought that it's a simple fracture. I put almost 5 screws in the head, and it's a sort of stable fixation, so I could mobilize early. So what happened on third post-op day is patient complained that she feels that her arm is not in her control. It was just moving, sideways. There is no control in her arm, and I did an X-ray, and one can see that there is there is a splinter here, so probably the screw has cut through and the fracture has displaced.
Can we wait a moment for this? So on the previous X-ray, so any opinion?
Pre-op?
Yeah, the first post-op X-ray.
Can you put that first X-ray where you put in that leg screw? Yeah. Can you describe how have you done this leg screw?
The fracture was sort of anteromedial, so I had to go more medial, but then because there is so much soft tissue which is attached medially, probably I may not have put through the center of the bone fragment. So I accept that it was not in right position.
I think the commonest mistake majority of the people do while putting a leg screw is they do not open up the two ends of that. Unless you open up the two ends and match those two ends 100%, it's not a leg screw. It's not an effective leg screw. So probably the same thing has happened here. You haven't really opened up the whole fracture from top to the bottom, two V's which they are going to meet there. And very rightly, as you mentioned, probably you have not done into the meat of the bone, where it has to be vertical, where is going to be a good fixation. Probably the screw, as I see, is in the lower end. You have a pointer here?
Yes.
Can you show the screw which is on the lower end pointer? Which is the one which is, there's the one. There's the one. So that's the one which is going to give you a avascular necrosis of the lower piece there. And that's the reason why it will go into a non-union.
I think with that, you can proceed with the problems you face.
I absolutely agree what Dr. Tata said. It was not a right fixation. Uh, uh, so it actually failed. So that was which happened on a third post-op day. Although I knew intraoperatively that this fracture fixation is not very stable, or it was not what I would have desired, but I did not expect it to fail on third post-op day. So that's the intra-op video. I'm not sure. If you can see here, that's the medial fragment. So essentially the fracture is just opening up on external rotation. So most of the time we see failure in locking plates at the junction of bone and plate. So whole of the plate has come off along with the screws, but here the failure is happening at the bone screw junction. Despite having 5 screws in the head, still the movement is happening at the fracture site. So this is what I wanted to stress with this case, that it is not important how many screws you fix. Even with 5 screws or 7 screws, you may have unstable fixation in proximal humerus if it is not done properly without following the principles. So I further thought about this fracture and I realized that it is an unusual fracture pattern. It is not the one we see in Neer's classification. It is a fracture which is starting from proximally and extending distally. All the rotator cuff muscles are still attached to the proximal fragment. So the supraspinatus is still attached here. The subscapularis and the posterior cuff is attached to this. So this fragment is very stable. So the function of rotator cuff is that they keeps the head into the glenoid so that the deltoid can act and abduct the arm. So there are such a strong forces which are acting on it. No matter how many screws you put on this, the plate the plate is essentially only on the distal fragment. So it is only the screws which were holding the reduction of the fracture. And I did not use the sutures in this because I was under the impression that it is just a simple 2-part fracture and I do not need sutures to use the tension band principle. That was probably the another mistake I've made. So that was the sort of fracture here, and putting a plate here, it is only the screw. If you're not using the sutures, it is only the screws which are holding the fracture, and no matter how many screws you put, it is not going to be stable fixation. So that's what I did. If you see the failed x-rays, the head has gone into varus. So I removed all the proximal screws. I reduced the fracture and used an circlage wire and put in plate, sort of 90-90 plate we use in distal humerus fracture. And then because the head has gone again into valgus, I managed to put the screws again. So probably they went into a different quadrant and I managed to get some purchase. So unfortunately, she had some persistent wound leakage at 12 post-operative day. I took her to OR and washed the wound suspecting to be infection. The intra-op cultures were negative, but I continued oral antibiotic for 6 weeks. So that's the X-ray at 6 months. Now, the story doesn't end here. She did not have very good active movements, but her passive movements were better. And I don't have the X-rays, but later on at 1 year I removed the implant and we did an ultrasound pre-operatively, and she had a rotator cuff tear. So I gave her an option to remove the implant and do a rotator cuff repair, but intraoperatively I realized that the cuff was not at all mobile, it was too much retracted. So I gave her an option of second stage surgery, but she didn't agree. So probably that were her end function. So I went through some literature. There is a paper on the reasons for early failure. So the authors have mentioned that malreduction is one of the factors, along with if there is a lack of medial support. Negligence of tension band suture of the tuberosities is one of the factors. Traditionally, it has been said that tension band sutures are more important in 4-part fractures, but there are certain fracture pattern where it is imperative even in 2-part fractures. There is another paper in which the authors have analyzed the predictors of failure. So we are all aware of these. If the bone quality is good and if the reduction is not good, or if there is a localized osteoporosis, like probably in this case, then screws are not going to hold the reduction. So what I learned from this case is that it was a different fracture pattern which was rotatory unstable, so you should be aware of such fracture pattern. And ability to operate is not an indication for surgery. I'm sure this fracture could have been managed non-operatively as well, so that may be debatable. That's it.
Thank you very much for a nice case, and nice that you brought out the problem you faced and corrected that. Any opinion on the case or any way? I would have done operative intervention for this patient.
I think in this fracture, conservative treatment is not indicated. If you do the conservative treatment with this long oblique fracture which is there, is going to displace. That's the reason I am saying that when you're putting it as an option of a conservative treatment, probably to me it is not there.
You may be right, sir, but even if it malunites, she would have better function than this. I'm not sure. But
Very nice presentation, doctor. But as you said that you were not expecting it to fail by third day, but intraoperative only you felt that it was not appropriate. But just one point, that it was a mistake of surgical tactics and execution there. As you were not able to go more medially. It was not needed. You could have put a lag from distal to proximal fragment. So these are the surgical tactics which we learn over the period of time. And anyway, we have to avoid going medially in proximal humerus to avoid the vascular supply. Plus, you had used 3.5 screws. It's better to use small fragment 2.7, 2.4 for proximal humerus. 3.5s are meant for tibia, femur, legs. So these are some of the things I think very important, rather than just trying to go from that proximal fragment to distal one by medially. You could have gone the other way also.
I've been doing dual plating since last 4-5 years, and I haven't had a case of avascular necrosis. So now I am more confident going medially, although those were my initial days and I could have put screws from a proper position, but now I am putting a plate in the same area and I haven't had much problem with that. And there are no biomechanical studies with 2.7 or 2.5 screws. I think they are too small and flimsy, especially in proximal humerus. There are where there are very high rotational forces. But it's just my personal experience.
Sir, you suggested to open it up both the V's on the medial side and in a proximal setup.
Cannot do a leg screw unless the fracture is 100% reduced, and it will not reduce in a long oblique unless you have gone higher up and lower down, clean out the edges, clean out those small V's and match those V's there, and then you hold it with the bone and then you lag it. I think you have not understood his problem probably. What he is talking about, the leg screw, only is 2.5 or even 3.5. The strength of the leg screw is not depending upon the whole principle. If you have been able to fix it up, I think 2.5 is going to be as good as any. Now, I have never used a 4.5 leg screw ever. Even in tibia and femur, as he says, it is always a 3.5. As a leg screw I am talking, we are not talking about the fixation of the femur, the whole humerus.
Last question on this case, and then we go for the next.
I want to congratulate you first for showing a failure case, because a lot of people don't show the failure case. Thank you very much for showing that. I think your case was a very good example of being a simple fracture getting complicated. In a sense, I think that fracture configuration is something where you lag it first and fix it, make it as one piece, and then you can go and plate it on top of that. That gives for additional stability. That might be the strategy that I would have followed, rather than doing separate plate fixation and putting screw through that. Anatomically reduce it, make it as a one piece by putting 2 or 3 lag screws and then plate it. You will not have any problems at all.
I absolutely agree with what everyone has said, but if you imagine the proximal medial part of the humerus, it is all covered with soft tissue. So practically it is a bit difficult to do that.
I agree. It's easy to say from here. It's very difficult when you are in OT. Yeah.
What everybody else is suggesting, two things. One, as Saab rightly pointed out, any spiral fracture, tibia, femur, anywhere, you will have to expose the whole extent. We are very reluctant about size of the incision. There is no compromise. It has to be the whole extent of fracture. The whole spiral has to be clamped with towel clips. And in this situation, temporary fixation can be done with K-wires over which you can slide your plate. And the leg screw is, none of us will pass a leg screw from medial to lateral or proximal to distal fragment. All of us will leg it from distal fragment, lateral to head side. And the direction will go on changing with the spiral. Plate will come over the plate. And as he rightly said, it can be 2.7 also. It will be equally effective.
So with
So
this,
other way around.
So with this, thank you very much for bringing out problems and correcting it. It was a nice case, learning points that we must lag the fracture first and have a plate, and you brought out the problem you faced. Thank you so much for that presentation.
Thank you.
Now we move on to the second case. May I call Dr. Nitin to please load his
Sir,
presentation?
sorry for interrupting.
We are
We're
starting.
actually ready for the live surgery.
Fantastic. So we are
Yeah.
ready for the surgical demo?
Yes.
Yes. Okay, we'll go ahead with it. Nitin, wait for this demo and then we'll go ahead with that. Okay. Thank
So
you
now
much.
we'll go to Ashirvad Hospital in Vapi for our first live surgery performed by Dr. Siddharth Patel sir, along with Dr. D.B. Patel sir and Dr. Mukesh Maurya sir. Also, we would request sir to moderate the surgery.
Siddharth Vainu.
Hi.
Good morning. Good afternoon from the hall.
Good afternoon.
Good afternoon.
Sorry for the delay, but I've taken up a challenging case. So I had some hiccups in between. So Dr. Ankit Kumar Desai will just highlight you on the X-ray.
So we are seeing, hello. Am I audible?
Yeah, you are audible. We are having some echo.
Yeah, one second. Hello. Now? Hello?
So it is better and we can see the X-ray very nicely.
Okay. If you are seeing the X-ray, it's a male X-ray of right humerus, left humerus fracture. And by the classification, the AO classification 1 to B2 type fracture.
So we decided to do a anterior bridge plate for this fracture. This is a bit lower in the lower part of the shaft, so the reduction becomes a bit of challenge. But we've already started and we've taken a recorded video for the exposure and how we have reached till the current position. If we've done a traditional anterior MIPO approach with the distal incision around of 3 centimeters above the elbow crease. The size of the incision is 3 centimeters usually. For this case, we have taken a little bit of longer incision. We start with the, we'll show you the recorded video on how we, so before we start, we check the position of the C-arm and whether we are able to see the whole bone, and with a plate, which is standard 12-hole locking plate, we do a C-arm guided identification of where we want to place the plate over the skin and just fix on our incision. Proximally, the incision is around 6 centimeters distal to the acromion. The length of the incision would be around 3 centimeters. And distally, as from the elbow crease, around 3 centimeters up. For this particular case, we had to extend the incision a bit more distally. So that is what we are doing on the video. And we usually start exposing the distal enough. We can move on to the dissection.
Can you just reduce the brightness?
The incision distally is almost on the lateral. On the lateral border of the bicep. There is some sound issue. माइक दूर करे तो नहीं थैंक
हिंदी हेलो
Yeah, we are getting your voice.
echoing present hello all side echo is present
Yeah, we are having echo.
અંકિત વિકાસ બોલું છું તારા ત્યાંથી સ્પીકરને એ કર થોડું બંધ કર લો કર નહીં તો એકો આવશે જ અને યુ કેન કન્ટિન્યુ ટુ પ્લે યોર વિડીયો so that we save on time. Your video is off.
વિકાસ ડોક્ટર વિકાસ
હા સાંભળું છું યસ ટેલ મી
ઇકો આવે છે
ના યુ આર ફાઇન નાઉ
Good suggestion.
Are you able to hear us?
yes
Yeah, we can hear you. So we can also
Dr.
see that
Siddharth's
you have
mic is working?
yeah, you have taken a skin incision and you are developing the subcutaneous plane.
We are hello
મારો માઇક ચાલુ કરને
માઇક ચાલુ છે સિદ્ધાર્થ વી કેન હિયર યુ
હવે આવે સર અવાજ
આવે છે યુ કેન ટોક
So we dissected the space between the biceps brachii and the brachialis, and we thought this is the musculocutaneous nerve, but it was a branch. You'll see the musculocutaneous nerve lying on the brachialis muscle in the later video. Retract the musculocutaneous nerve with a part of the brachialis muscle, hence protecting it. And laterally with the RV-Navy retractor, we retract the lateral half of the brachialis. That will protect the radial nerve, which lies between the brachioradialis and the which lies lateral between brachioradialis and the brachialis. So we are protecting both the nerves. The crux being here is we are not using a Homan spike and we are using a retractor. Moment we do this, we are onto the bone.
So you have incised brachialis in the middle. So you are planning to put the plate on anteromedial surface? So if we can ask you, these two drill points have already been drilled up?
Can you see how it comes in a pre-sterile gamma pack, gamma radiated pre-sterile pack?
Yes, we can see that very nicely.
That's a gold plate, so it's just on gold, and it's quite brilliantly looking plate, but the principle of the plate is the same. It's a locking plate, a combination locking plate. There are several methods described for anterior humerus plate in which they slide a plate, align it distally, and put a cortical screw first. What we've done here is we have split the plate, we put two drill sleeves over the locking screw, and we've just put on a drill and left it there. So that just gives us an sort of reduction, provisional reduction. I will show you on the TM what reduction we have.
It would be the series of CM pictures which shows the sequential reduction maneuver and the parking of plate and the facial periosteal elevators, how they are using it.
So can you tell us where precisely you are going to put the plate? Anterior surface, anterolateral surface?
Sorry, I cannot hear you.
So where are you going to put the plate? Anterior surface or anterior border or anterolateral surface?
The anterior surface, in this case, we may be a little bit more laterally, distally, but he has an unusual
Bony profile?
and as well as the fracture is bit on the lower side, so that is why we are accepting this because it does align the fracture well. So on the left screen is the current fracture reduction on the ED plate. Now what we are going to go ahead and do is we are going to put two cortical screws, drill two cortical screws and tighten them together. So that will give us an reduction in the lateral chain as well. And then we'll check on the lateral chain how we've done. We may not be successful in it, but we'll go ahead and do that.
So plate is put from the lower surface proximal.
So plate also has been slid from the distal to the proximal surface.
Right. Thank you.
For the reduction of such fractures, a temporary enders or even a permanent enders is very useful. You put it the ender there, the fracture is reduced, and now you do not struggle to get the reductions, which otherwise in AP view and lateral view both way it may not work. Once the enders is in, it is only the traction and nothing else which you need. And then whether you want to keep the enders or take it out is your choice.
Yes, sir, I agree, sir. So we've kept what something similar to an tender cell. I prefer an L wire or the Danbury wire, sir, because I find it more malleable and more smoother to insert. But we could get a reasonable reduction, so we've not done that better. But definitely, sir, it is it's a very very helpful sort of a method to reduce the fracture.
Also,
we are giving in traction, and once one person is reducing the Varas target, and now I'm going to, so he's going to, one person is holding the reduction, and I'm going to bring a cortical screw proximally and distally.
also, sir, in this case, when we need to pass the plate from distal to proximal, you have to extend the elbow. That tightens the anterior musculature and it becomes difficult. So personally, I find putting it proximal to distal is easy with flexed elbow and reduced fracture than the other way.
So the most difficult part you feel is sliding the plate in. So either proximal to distal or distal to proximal.
So if you need to pass distal to proximal, we need to extend the elbow. It tightens the anterior structures, even becomes more difficult. So better to put proximal to distal in flexed elbow.
You are not tightened it. Similar I do it distally.
So you have drilled the hole and put the screw but not tightened it.
Yes, sir. You have put the screws and not tightened it in a circle.
The aim of that is that you can maneuver the plate and you can finally reduce it better. Is that your aim?
Sorry, I am not able to.
Yeah. So your aim of not tight.
Yeah, sir. So for the reduction in the lateral plane, if I tighten both the screws together, it sequentially brings the both towards the plate and would help us in reducing the fracture.
Yeah, perfect.
Have you taken any of the lateral view?
Initially, yes. After partially putting the screw,
You are going to take it.
So what is the ideal position to do ABP? Limb of the patient. Is it 30-degree abduction, an external rotation, or in a flexion?
I could see the displacement of the fracture, will just check it on the CM. Yeah.
There is
Should
a
we do in a flexion?
Yeah. So
Yeah.
So we are able to see that very nicely. There is a question What is the best position to do angle the ABP? Yeah.
Ankit, you need to increase the volume there. Slightly increase your volume. Can you hear us now? So the question is, which is the best position of the limb to do this procedure? No.
Sorry, I forgot to mention the elbow is in flexion and in complete supination. The forearm is in supination that helps the lateral, the radial nerve to go more naturally, going away from our operative side. So it is, and we check the rotation with the epicondylar axis is perpendicular to the bicep.
Okay. Does that answer your question? Yeah. They're asking the shoulder abduction also, Siddharth.
Shoulder is kept, so shoulder is kept at around 60 to 90 degrees of abduction.
Okay.
I'll just put this to because
Okay. That's okay. Fine. Do that.
important to do that and then
Yeah. Please concentrate. No problem.
and then I'll answer the question. So this has happened because when I'm trying to put the screw, my direction is not perpendicular, and hence I displaced the fracture. That's what. As the plate was off the bone, I'm seeing at 28 on my Descartes diagram. This is a 26 tooth. So then tools also come in greaser and wax.
They are also golden screws.
Yes, sir. So we already have a 26 screw in my hand. The next screw will show you how it is. It's a golden screw and it is self-tapping. Usually there is not much struggle because nobody is watching me. I can shout, abuse. Today particularly I have to be calm.
But you are executing very perfectly. So go ahead, please.
Relax. Thanks, sir.
Relax.
Well,
The point to learn is you have perfectly put the plate anchored with two drill bits in two holes, and then you are fixing two screws on either side of the fracture.
Now I am tightening both these screws together, hoping it will help me in my lateral reduction.
I think that's a treat to watch, both these screws being tightened simultaneously. So that's a point to take up.
Tighten both the screws and now we look at the alignment in AB and lateral plane. I hope you've done a fair job. reasonable reduction in the EP plane. Let us see how we are doing on the lateral plane.
On the large screen, we feel some amount of distraction is there. That is what your feeling is?
I guess so, sir, but we may not get a very good compression on when we are doing amiibo. What we look for is a reasonable bony contact.
Okay.
I guess there is a small spike in the central part, which is in bony contact. So I'll have to look it up in a lateral view and see how we are doing. If we are not okay in the lateral plane, then we may have to redo the cortical screw thing. This is a bit, so we are not okay on the lateral plane, so that's why we are seeing the distraction. I guess we need to loosen the screws and go ahead.
Sir, I want to ask one question. Like, whenever we have a plate with a hole for the K-wire, I think this plate does not have the hole for the K-wire. That's why the bits are being put in. So when the screw here is being put in a centric position, just to get the bone close to the plate, because there are drill bits on either sides, that is the one reason that probably compression didn't happen. Because once you have the wire and we fully tighten the cortical screw, wire gets bent. So just before fully tightening, we have to remove the wire. So is the drill bit on both the sides causing a problem here? Or should it be removed while final tightening it? Because this place does not have a hole for the K-wire, that's why bits are used. So that's one question, because it will unnecessarily put stress over the drill bits and they can get broken if so this probably didn't happen because the bits were inside.
So your suggestion is instead you could put a small 10-min pin.
Yeah.
Yeah.
As you can see, we put the drill bit only in the far cortex, near cortex, not the far cortex. So there is some amount of play which will be there, and I use a locking sleeve, whereas I use a simple 3.2 drill bit. So that gives me a little bit of play when I am tightening the screw.
While tightening,
Lateral view now, but you are correct. If I'm holding it one thing, I'm not going to get compression when
Yeah.
I'm putting cortical screw.
same as when we are holding with a bone clamp. So when we are tightening the cortical screw, just we little bit loosen it. So
But here we are not looking into compression because
no, here you want the plate, the bone to come close to the plate. So in that also you should just take it out.
Yeah, we can appreciate
Yeah.
that. Appreciate that.
It
And
will-
your logic of putting
Unicortical.
unicortical is accepted very well. As you can see here, he has used it on the unicortical side. Therefore, you have So for getting the reduction, you manipulated the fragment or you put a towel beneath the mid arm, something like that? So how did you get that reduction? How did you get the fracture aligned in the lateral plane? Okay. Okay.
When should we use a broad LCP or this
So-
narrow is always okay?
So the question is, do you prefer a narrow DCP or a LCP or a broad one?
My observation on this MIPO surgery, originally it came up for a comminuted fracture, where you do the bypass plate, you will get a good callus. It has been extended to these transverse fractures or a small fracture like this, where if you can get a good reduction, this is perfectly all right. You will get a callus formation, which otherwise posteriorly you go down and do a compression, you may get a primary healing. Now the only other thing I have observed is, operating upon young ladies, there is a big scar anteriorly which is not appreciated. While there is a posterior scar, if it is there, is not seen by the patient herself. And that's the reason that anterior scar at times, even if in case it becomes spreads out or something, then it's cosmetically is not a very acceptable situation. And this obviously I am talking about young means even 50-year-old also see objects to that.
Ankit, can you show the other video where you are sliding the plate? Because the video has not been played.
Another question, Ankit, you are going to use only 2 screws at the end of the plate, or you are going to use 3, or hole number 1 and 3 from top and again leaving 1 in between? What is your configuration? Can you listen?
Ankit, are you there? Yeah, Ankit, can you hear? So one is, are you playing the video where you are sliding the plate, which is yet to be shown? No, but the video has not been, we cannot see that video. So, yeah. So this is, I think, what you are showing now is, yeah, okay.
Periosteal elevator is going.
Yes, yes. Siddharth, there's a question. Can you hear? So how many screws do you plan to put proximally, and how many screws do you plan to put distally? Okay. Yeah, so it was the screw configuration, you know, how many screws are you going to put proximally and how many screws distally?
If I do the same thing proximally, very proximally, then put
see a secondary displacement of the fracture. So Phillips
Yeah.
screws is my technique. Literature has no consensus on whether we need to screw the field.
That's great. Siddharth, so now we will will we applaud the entire VVF team. You can just show the IITV picture and then we would give you a time to come back. In the meantime, we can have a presentation here from some other speaker. Is that fine? Yes, yes, that's perfect.
Might be Dr. Khanna has asked regarding the anterior scar and posterior scar. Right? Am I right?
Yes, but we can do that discussion later. Ankit, we'll go ahead with few presentations here and then we'll come back to you.
Implant guy wants to show the packing of the screw and
Screw comes in a pre-sterile pack. Again, it is gamma irradiated. One pack has 5 screws of the same size. So this pack will have this doesn't move. 20. So 28 box will have 5 28 locking screws and similarly for cortical screws.
That's wonderful, wonderful, yeah.
It's a wonderful way of one is sterility because gamma irradiation is probably the best way to have sterility in for our patients.
Thank you very much for that wonderful demonstration and a big round of applause,
Applause
from all
for
of us. Yeah.
let me tell you, this is Vapi Valsad Orthopedic Forum team. You know, for the first time, the entire team of orthopedic surgeons from our place went on to do a live demonstration. So I think they deserve a big applause.
And that was done wonderfully with good take home.
Chalo, we can go ahead with the presentations.
And after that wonderful demonstration and taking home some points from that, may I invite Nitin, please. Again, a proximal humerus case. And proximal humerus is always exciting because it at times gives us problem, and at times when you see a first check X-ray, you find out something better you could have done. So let us see, Nitin, what you have done.
Good afternoon all. Greetings from Kerala. I thank the team of Merrill for giving me this opportunity to present a case. So I present to you a case of 47-year-old female patient who presented at midnight with a history of domestic fall on October 2020. She had a medical history of diabetes mellitus, hypertension. She was already coronary artery disease patient on ecosprin, clopidogrel. This was the X-ray with which she was called into the ED. So my team attended the case. So the fracture location was left proximal humerus 4-part comminuted fracture with anterior shoulder dislocation. Fracture classification was AO11C3. So the challenges that came to my mind soon after seeing the X-ray was high chance of AVN, osteopenia. I don't know the condition of the rotator cuff, wound infection chances if I operate, chance for implant failure, need for resurgeries. All these came to my mind soon after seeing this X-ray. So all the recipes for a poor outcome.
Yeah. Just wait a minute. So at this point of time, he raised a point, he doesn't know the condition of rotator cuff. How many of us would get imaging for assessing that? Did you get imaging for that?
No, I just took a CT.
Took a CT.
CT.
Any opinion from the house? Anyone would like to comment on that? So how many would get a MRI done for this fracture for assessment of X-ray?
Yes.
So raise of hand, how many would like to treat it operatively? So majority would like to do operative fixation. And the choice of fixation for majority would be a plate Philos fixation. I think the majority consensus. And how many would like to treat it percutaneously? So majority would offer a plate fixation. You please go ahead.
Yeah. Unfortunately, I don't have the CT images. Sorry for the inconvenience of that. I have a report on that.
In this case, he doesn't have a CT.
CT
But yes,
films
the
I
point
don't
is
have.
taken up well. All intra-articular fracture we would like to assess with the
CT. So my concerns and options were whether to operate on that patient or non-operatively treat it whether to do it at an emergency, as an emergency surgery or delay the surgery, whether to go for an open reduction, closed reduction, or take in for a hemiarthroplasty, how to position the patient, whether beach chair or supine, whether to give GA or regional block because she is already on ecosprin clopidogrel, what approach should I go, deltopectoral, deltoid splitting. So if at all I operate on her, whether K-wire, Philos, what type of Philos, titanium, stainless steel, whether to put a drain or not, whether to immediately mobilize or blade. All these came to my mind in the midnight itself. We had a discussion with my team. Then we took up the case. She was a poor lady, so we tried to reduce it from there itself in the ED. And then we sent for a CT. CT report came as comminuted fracture dislocation with 4-part in the surgical neck, lesser tuberosity, greater tuberosity, and the articular surface was split. And then what I did was I had to convince the anesthesia team to give me anesthesia, give the anesthesia, and they told that it will take around 3 days to stop it. And then we took at the patient for surgery on the 4th day. I positioned in supine position, GA was opted, deltopectoral approach was done. This was the incision. I identified the occipital vein. Then retraction was done. Fracture site was identified, meticulously dissected. These were the plates which was available with us. Implant of choice was stainless steel Philos. Cuff stitches was applied. Temporary fixation was done with K-wire and then tied to the plate. This was the fixation done. CM pictures were looking pretty okay. And this was a X-ray soon after the post-op. In the SICU, this was the X-ray that came to me.
So now he wants an opinion. What do you feel? This would go for a uncomplicated healing, or you anticipate some problem? Any opinions? Anyone can open?
Under CM, it was pretty okay, but
AVN is always a possibility, which is not in our hands. It is the fracture.
That would be a delayed problem. Are you happy with the greater tuberosity?
Nitin, that GT. Can you point it out with your pointer? You got a pointer there. Yeah, we also have got a pointer.
GT should be lower than the head.
yeah,
Yeah.
it should have been. Under CM, it was pretty in good alignment. I don't know what happened. Reduction, I was satisfied with the time in which I closed the fracture, but this CM picture deceived me, or rather, I got the post-op X-ray as this one.
So many times, when you see the GT, actually, there's a big piece which is seen there, which you put it down. But in the CM view, when you will find out there is some piece which is lying down. So it's a comminuted piece which is lying posteriorly.
Yes, sir.
That is the where the infraspinatus is attached.
Yes.
So that posteriorly, so unless and until you go down again and pick that piece and put it down with the threads, then only it will come out. Otherwise, that posterior piece remains proximal. This is what has probably happened here.
So we
For the
again,
nature
I find the head fragment is too small. So
I think
probably all those screws which are going there and into this sort of a situation, whether he is going to hold on to it or no, I am very doubtful.
I would say for the nature of fracture, you have done a reasonably good job. Only thing is, only intraoperatively you will know whether if you have gone through the rotator cuff with multiple stitches and make sure your fiber wear is well taught in, then you will be okay with this X-ray, no problem. That is only intraoperative, you only know it. Because this looks like GT might pull out. But it's one view, we cannot comment on that. But if you have done a very good fiber exchange, it will stay, no problem.
yes.
The
It's a
issue,
valgus reduction you have done.
My
Head
aim
of
was to-
humerus is valgus reduction, so it's fine.
My aim was to maintain that valgus. The slightest malreduction, I didn't pick up in the CM.
the issue is here, the head is in more valgus, sir. Therefore,
Yes.
the GT is not sitting. That is the major issue. It is not in neutral angle. Therefore, as it is in valgus, the GT sits over the head, not in the groove where it needs to sit.
Okay.
Therefore, it is an excessively valgusly reduced hip, or not, the valgus is not corrected completely.
Okay. I take the point.
So let us see the further
Okay.
question.
So post-op number 12 suction drain was
Now,
kept.
with this history, medical history which you described,
Yes, sir.
and how old was she, you said?
47. 47. Yeah. So I kept a drain and applied shoulder immobilizer, then post-op. Then further physiotherapy protocols were given as active and passive as tolerated. I had that X-ray image in my mind, so I didn't force the physiotherapy onto her. Patients and bystanders was reassured that there is some malreduction, it might fail. It was reassured and then sent home. Advised to continue physiotherapy, strict diabetic control and frequent follow-up was advised. Unfortunately, there was COVID surge in our state at that time, and she was lost to follow-up. Then 6 months later, she presented to me by this X-ray taken elsewhere. She came with a slight pain in the shoulder, and to my surprise, it was holding well.
So why were you surprised? So technically, you had a Calcar screw.
Yes.
And you had 5 other screws holding.
Yes.
So what was your fear?
I feared that the GT, I didn't actually have any stitches in the greater tuberosity. So it was actually pulled out intraoperatively. I felt that it was day 1 failure for the GT. So I was keeping my fingers crossed she would come back any day. But 6 months later is what she turned up. Then that piece was lying there itself. Actually.
But the GT not put in properly, it has nothing to do with the fracture healing. It is to do with the function.
Function, yes, sir.
And that function is going to be, if it is deficient because of that GT, then probably she is going to have that problem.
Yes, sir.
So the
Functionally,
fracture healing is purely onto your screw hold and the neck there.
I think there was some varus collapse which happened.
Can you show us the function?
Sir, she didn't allow me to take a picture at that time. She just showed me the function. It was about active degree of 90 degree. She was doing 120 degrees of flexion and 20 degrees of internal rotation. Extension was there. Internal and external rotation was okay. She was happy with her shoulder functions. She didn't have much discomfort at that time. So my professional diagnosis at that time was IDC capsulitis, varus malunion with a bony spur or malreduced GT with a plain impingement. So I had a discussion again with my team whether to continue physiotherapy until satisfactory abduction can be achieved, whether to remove the plate and do a manipulation under anesthesia, or arthroscopic excision of the bony spur or GT with a subacromial decompression, or a combination of all of the above. So I had a discussion.
I was exactly thinking about what you are telling now.
Yep.
Because this is a typical case where you get impingement.
Yes, sir.
Where there is a malunion of the greater tuberosity.
Yes.
I think the way forward is that's what you already mentioned, the arthroscopic excision only.
Excision.
That will cure the problem mostly. Yeah.
So I discussed with the patient, but she was not convinced for a resurgery because she was doing reasonably well. So it's a left side, so probably she opted for leaving it. I also didn't want to touch her.
So you have accepted that, and patient also has accepted that.
Yes. So my take-home message would be a proper pre-operative planning with good quality X-rays, CT scan, and adequate training to achieve surgical expertise are important. All risk factors should be documented, and proper, well-informed consent should be taken. And adequate exposure of the fracture and proper reduction is the key to success. And a minor malreduction can be reflected in the post-operative functional outcome. Main surgical difficulty is achieving the fracture reduction to anatomical position, and maintaining the position is the greatest challenge. And then good post-op physiotherapy is a must, and it should be frequently followed up. And position of the plate, it was earlier described by Negi sir. It is to be accurate and lower than 8 millimeters from the apex of the greater tubercle. And the varus malposition, it can be defined as head shaft angle of less than 120 degrees. So this is the ideal plate position. So irrespective of all this, I would suggest that currently Philos is the best available construct and a stable implant to use for fractures of the proximal humerus in second, 2-part, 3-part, and 4-part fractures, especially in elderly patients and osteoporotic fractures. And it allows for the early mobilization of the shoulder. And surgeons should be aware of all the potential complications, plan the surgery meticulously, and patient should be counseled about the outcome. I was more thinking in terms of avascular necrosis, varus malunion, all these things. I didn't never think in terms of slight mal reduction affecting the functional outcome. But all those parameters has to be taken into account while doing philos. Thank you.
Thank you very much for showing up a good case and evaluating that case very well. Yeah, please come in. Can you use mic? Just step down 3 rows and you'll have a mic in front.
I want to ask you, Dr. Nitin,
Yes.
in case of using a deltopectoral approach and in case of using a deltoid split, do you feel that that fragment of the GT is more better approached with a deltoid splitting and you can reduce it probably better?
Could have, but my...
I have felt so in few cases when I am using a deltopectoral, sometimes the posterior fragment is very difficult to approach with, I have to release the deltoid a little bit anterior fibers and then I have to approach it.
Okay.
So I wanted to ask you whether that be...
Could have been. I am well versed with this approach. I was confident, that's why I chose this approach. Your point is well taken. It could have avoided this complication.
Doc, what is feasible is that people who are not very accustomed with split deltoid or anterolateral, let them do the deltopectoral, especially in obese patients in a situation which you are describing. I will take a separate, small, about 3.5 centimeter incision on the lateral side, look for that, hunt for that piece, take my sutures there, and with an artery or some instrument, I pull that suture in the front wound. So main surgery he can do with the deltopectoral. The split deltoid needs training and lot of exposure, comfort with that approach. So let them do with the deltopectoral, and a small 3.5 centimeter incision is safe. Nerve is far away. So use only that to take the suture and tunnel it through, bring it forward.
One more thing, while using the sutures to tie the cuff with a plate, do you find it difficult with a needle, 3/4 needle, passing the sutures through that? In some particular philosophy, for example, AO, it is very difficult to pass it. That is for me.
The sutures are passed without needle. The suture itself goes through the hole, and that is before I place the plate. In the hand, I do it, not after putting the plate on the board.
No, that is not obviously. Obviously, before the plate is fixed. Thank you.
That is always an art. You have to think about where the GT needs to be brought down. So selecting which hole to get those suture in is really, you have to understand, taking into account the whole team and the configuration where the GT needs to be brought down.
And usually the passage is done by the junior person. His eyes are sharp and he does that donkey work.
Thank you for your
decide where to
experience.
place the suture.
So
just thank you for sharing. Sir.
Yeah. Please, you wanted to comment? Please go
No,
ahead.
sir.
Yeah. Thank you so much for presenting and bringing out the points very well.
Thank
it
you,
was a
sir.
good case.
Thank
Thank
you,
you. May I invite Dr. Subramaniam for presenting his case on proximal humerus fracture again. And these are always interesting cases.
Sir, just one point about that posteriorly placed GT there. So most common error which in early times what we do is that we take a suture posteriorly and we think that is the main suture. So the initial suture is just to pull the GT forward. You have to take multiple sutures, you pull the first one, take one behind it, pull that, take one behind it, so that whole of the GT comes in front. If you just seeing what you are taking and just tying that, your GT will always lie posteriorly.
So point well emphasized. You need couple of sutures in the fibro-osseous junction exactly. So first thing is to get the GT forward, and then is the more effective second suture, and then is the third suture. And then you keep on tensioning. It's like a wren. You just keep it into position, and then that is the effective end. Very nice point brought out. Yeah, go ahead please.
Thank you, respected chairperson. Sorry, mine is not a case presentation.
Yeah, please go
Because
ahead.
I was told that to give a 20-minute talk on management strategy.
Please go ahead. No problem.
So this is
As
going
has
to be a
been
slightly different talk. And I would like to thank the whole Merrill team for organizing such a nice event. My talk is going to be on what is the main principles of managing proximal humerus fractures. That's what I'm going to say. So concerns that we have is non-union, avascular necrosis, malunion, and the secondary problems like stiffness, degenerative arthritis, impingement, and nerve damage. But if you look into the type of management, we have papers for both favoring surgical management as well as we know the Goodhold Profer trial, which says there is no difference between the operative management or non-operative management. So our question is that will surgical management bring a better outcome? That's what the question I want to answer. And possibly yes. And how is it is we have to identify what are the variables that are determining the good outcome for us. So in order to do that, if you see, look into the lot of classifications, we have like AO classification which describes from extra-articular unifocal to extra-articular bifocal and then intra-articular. And then we have Habermeyer classification which tells about type 0, A, B, and then C and X, which includes about anterior and posterior fracture dislocation. And Hertel classification describes about how to predict ischemia of the humeral head, how to predict avascular necrosis. And we look into our Goodhold near classification, which tells about 1 part, 2 part, 3 part, and 4 part, and along with the displacement as well as the angulation. So what is the inference of all these classification is it's telling about the severity of the injury and also tells about an outcome of these fractures. It's very difficult to put classification into concept in each and every case, but the basic line is how to identify the injury severity and also to plan management. That's what I want to highlight now. So what will I look into X-ray or any CT scan? First is I want to look into where is the fracture location? Is it surgical neck or anatomical neck? What is the status of tuberosities? Is it displaced or comminuted or undisplaced? And is there a dislocation of the head, acute or chronic? And then what is the metaphyseal related hinge? Is the metaphyseal being supported or not? And is there a head split fragment? These are the 5 factors which are going to determine the outcome of any particular patient. So I want to tell 6 factors which you have to look into for outcome of proximal humerus fractures. Factor 1 is, I think we already described about this thing, head shaft alignment. This is the key point that will dictate the outcome. And as earlier somebody described about this slight impingement, I have this case who is a 59-year-old, which seemingly looks like an undisplaced fracture, but there is a small fragment over the, it's just like almost like head split fragment. If you look over there, I just managed non-operative only for this patient, but on a due course of time, in about 6 weeks time, the patient had a slight varicose. Though the fracture united very well, the patient is having some impingement. So any varus malalignment is not going to be good for the patient. They are going to come with either a fracture displacement or they can even have a subacromial impingement, as like this case where you have a very good reduction, but in about 3 months or 4 months we see that there is a varus still, the fracture united, but similar to the case that was shown earlier, this patient is having impingement problem. At the end you have to go for a implant removal and if needed arthroscopic subacromial decompression. So the factor 1 is make sure the patient does not have varus malalignment, because it is always a problem. Try to make a neutral or a valgus foil fixation. That is what is the key point. Number 2, make sure the status of tuberosities have been well placed. Remember, greater tuberosity is not a bone, it's a muscle. It's a rotator cuff, supraspinatus and subscapularis. These are the 2 important ones, which are the workhorse for the shoulder joint. If these are not functioning, it can be classified as a dead shoulder. So, if you look into some examples, this is a GT fracture with anterior presented after 5 days. So, if it is 5 days, it's not going to go by close reduction. So, I did open reduction and did plating for this. So, plating did very well. Similarly, another case where you have like a chronic dislocation, more than 2 weeks old. And this also, again, you need to have a robust fixation of the greater tuberosity. Only then it will work. If you want to do a robust fixation, you can do any type of fixation. I chose plate for this also, to make sure you have a robust fixation. But only then you can get good reduction and good function also. And this case is where you have a patient who has got a flaky fracture of the greater tuberosity. It's an acute fracture. I went to go for a arthroscopic fixation. Arthroscopy you can do with the anchors. In about like few months time, the patient is having very good function, excellent result. Arthroscopic fixation of a greater tuberosity has got an excellent outcome and they can have a satisfactory function. So remember, greater tuberosity plays a big role in all the shoulder fractures. So factor 2 is tuberosities are the most important, should be given importance, and it is important for the good function. Next is the fracture reduction medially. This is a very important factor. So for example, look like this fracture which somebody showed earlier, like there is a greater tuberosity fracture, There is a humerus head which is slightly valgus in place, and there is a lesser tuberosity fragment also. The most important thing in this is achieving that medial support. If you don't get that medial support well, then there is a chance of failure. So medial hinge is the most important. I have quite a few examples. This is another one which has got a head fragment, greater tuberosity which is totally displaced, and the lesser tuberosity fragment is also displaced. But here what I have done is I put an anchor to fix the greater tuberosity. I use a bioabsorbable anchors in the head of the humerus and take multiple sutures through the rotator cuff and fix it with a lateral anchor also. These are all biopsies also, you're not able to see it in the X-ray, and achieve the medial support also nicely. If you achieve the nice medial support, the patient will have a very good function. So the key here is you have to achieve the medial support. That is very, very important. That is the next point I want to emphasize. So factor 3 is medial hinge or good medial support, maintain satisfactory reduction. Next is factor 4 is age and bone quality of the patient. For example, this patient who is 64-year-old, this patient came in 2012 to me. It's almost 10 years before. She came with a fracture dislocation, which is greater tuberosity is broken, head of the humerus in varus tilt, and is also dislocated also. I went in for doing a hemiarthroplasty. Because considering her age and bone quality, I went for a hemiarthroplasty. I managed to get a reasonable reduction of the greater tuberosity. But if you see it in about 3 months' time, the GT has resolved. That is because the greater tuberosity bone was not in good quality. At that time, I did not have the good knowledge of reverse shoulder also. So I accepted that the patient is not having pain, but is not having a good function. Hence, the patient is not satisfactory. So, in an elderly osteoporotic, even a seemingly good job may fail because the bones are of not good quality. You have to make sure, you have to address it in a different way. That scenario, I should have done a probably reverse shoulder replacement that time. I did not do it, but the patient had a loss of function that is pain-free. Next is bone loss and soft tissue issues. There are occasions like where you come like fracture dislocation. This is a patient who has got a chronic fracture dislocation, which is been dislocated for few weeks, and patient presenting like that. Here there is this patient also has a glenoid bone loss also. So you have to address soft tissue loss, soft tissue tension. You have to address glenoid bone loss to maintain the stability. So for example, this particular case, what I have done is I have done Latargia procedure to restore the bone loss, and also I put anchors to fix the rotator cuff, because any elderly individual coming with a chronic fracture dislocation, invariably they will also have a rotator cuff tear also. Remember that. They are not only going to have a glenoid bone loss, they will also have a rotator cuff tear also. They have to fix the rotator cuff, you have to do the glenoid bone loss correction, and you have to temporarily keep these transfixation pins in order just to get the stability back. I won't use this transfixation in acute fractures. Only in a chronic scenario where it's almost 2 or 3 months, the soft tissues are contracted. I use a transfixation for a period of about 3 to 4 weeks. That's all. So this is another one where you have an electrocution and has got bilateral shoulder fracture dislocation, and but it's a young patient, so you have to go for but the head is totally intact. Intact in the sense it's not split. It's dislocated, but it's not split. Hence I went in for fixation. Here also the principles have to be maintained, like you have to maintain that medial hinge, you have to get that greater tuberosity fragment corrected. You make sure the plate is well positioned, then you have a good chance of healing. Still this patient went into for AV on one side. I have done reverse shoulder for this patient after like 1 year. So this is another case, 28-year-old, neglected fracture dislocation, has got a glenoid fracture also. Glenoid bone loss is more than 30 to 40%. So you have to go only for options like doing a fixation along with the coracoid osteotomy, doing a Latargia procedure. These are the extreme scenarios. So what I am trying to say is, very important is make sure the bone loss has been addressed and make sure the soft tissue tension has been adjusted correctly. This is the 5th point that is very, very important. And the last point is combination of many factors. These are the extreme scenarios which I am going to say, where a patient comes with neglected fracture dislocation, 4-part fracture. Tuberosities are in a non-reconstructible way, which means they are not in single fragment, they are in multiple fragments. Here are the case where you cannot go and fix it at all. And the only option you have to go for a reverse shoulder replacement. There are many scenarios like this to me. Here like a patient who has come from Nigeria, who had a chronic fracture dislocation, where in Nigeria they did Latargia procedure, after that she dislocated again. Here the rotator cuff will not function. Only option for this is doing reverse shoulder, and reverse shoulder will have a phenomenal functional outcome. So that is the next thing I want to emphasize. There are occasions like where here head is totally eroded. Head is not there at all. You can't reconstruct the head. There are situations like this, which are extreme scenarios. No other option other than doing a reverse shoulder replacement, which will really work very well. And like this, where you have like fracture dislocations, where the reverse shoulder is the best option. Like this kind of scenario where patient had a previous fracture some 6 years ago, where they had a femoral head resection. The only option for them is doing a long-stem reverse shoulder replacement. This patient had a reverse shoulder replacement. In second week itself, they dislocated because there is no muscle function at all. They had to put in a constrained liner to get the stability back, and then he was doing well. So the factor 6 is combination of factors like where you have a non-reconstructible graded tuberosity, bone quality too poor, elderly, fixation may not work at all because the plates will not have enough strength to hold it because the bone is not good enough. Then you have to think about different strategy where the reverse shoulder replacement in the recent days has done a very good job and is having a very good improvement in the functional outcome. So the indications for reverse shoulder replacement are cuff tear arthropathy and massive rotator cuff tear with pseudoparalysis, severe inflammatory arthritis with cuff tear, failed shoulder arthroplasty, and there are situations in non-fixable proximal humerus fracture, non-union of proximal humerus fracture, non-reconstructible bone loss, and reconstruction after tumor removal. This kind of situation, reverse shoulder has done an excellent benefit. So decision making and management plan in proximal humerus fracture. 6 factors to consider. This is something I want to highlight for all the juniors who are here. Factor 1 is make sure there is no varus malalignment. Factor 2, respect the tuberosities and make sure the tuberosities have been well addressed. Factor 3 is make sure the medial reduction is very good and medial support has been maintained. And factor 4, the patient has got osteoporotic bone, think of not just fixing, there may be something else you have to think about like replacement. And if there are bone loss, you have to address it also. That is a factor 5. And factor 6 is think of reverse shoulder replacement in cases where you think you cannot address with fixation. Thank you very much. So the goals to achieve in fixation are these are the goals. Thank you.
Yeah, what's happening here?
Live, hello, am I audible?
Hello.
Yeah, we can hear you.
Yeah, now we are transmitting the rest of the position, where we have left.
Yeah.
I'm handing over to Dr. Siddharth Patel.
So we finished the case. If you can see on the C-arm, proximally we've put 3 screws.
Yes, we can see that.
That's the lateral view fracture in the lateral view, very well reduced.
Yes.
Distally we've put 1 cortical and 1 locking screw. I did not put a 3rd screw because then I'll become very close to the fracture site.
Okay.
And that's the AP view. We have a good, not a very good, but relatively good bony contact. So I would have had my plate a little bit more medially than laterally, but I've got good hold on both the screws. I've got 2 quartices. So I'm pretty happy with what I've done, and I hope God helps him and me for union. And now we'll be closing the skin with Vicryl and Ethylon. So finally, if you can look at, that's the wound, and we can easily do elbow flexion extension. Zoom out karo. Zoom out karo. Zoom out pura, or, yeah. So we are able to do full movement intraoperative, and postoperative protocol will not be giving him any sort of slabs. We'll be putting his hand in an arm pouch, and moment his pain relief, we'll advise him active movement in his pain tolerance. I'll be doing an X-rays at 3 weeks, 6 weeks, 3 months and 6 months. If I can get an email address of all you guys who have watched me, I'll probably email you after the union happens to this very kind patient. With this, I'd like to thank my team, Dr. Mukesh Maurya sir. He's my senior and a mentor. Always guides me and helps me out. My colleague, Dr. Sameer Patel. My colleague, Dr. Ankit Kumar Desai. So he's very tall. I'm standing on to actually match his height. And most of all, I like to thank our anesthetist, Dr. Jigar Desai, and our kind patients, and thank you for tolerating me. Thank you.
Thank you so much for demonstrating a wonderful.
Sorry, sir, I forgot my staff nurse, which is Usha Patel.
Yeah,
she has more experience in orthopedics than my age. So she's
So-
also an essential part of
Sure.
the team. Thank
Yeah,
you very much.
yeah.
This is a signing off from the OAC.
Thank you so much for the whole operating team. Great job done. Good surgical exercise, good reduction. We must compliment all of you. The whole team needs a good, big applause. Thank you so much. Thank you.
Thank you.
Thank you so much. And we'll be continuing with our presentation sequence here. I must thank Dr. Subramaniam for. So, yeah, please.
Thank you, Dr. Subramaniam, sir, and for the live surgery that been gone through. Now we are going for the second live surgery, for which we request Dr. D.D. Tanna, sir, Dr. Chandramouli, sir, and Dr. Manucha, sir, to increase the stage, please, for as a moderators for the second live surgery.
And I must thank the audience for wonderful patience and good interaction. Thank you very much for this opportunity.
Thank you so much, sir, for all the support.
કરતા હોય એટલે આ મારે શું છે કે ખાલી મારું ના sorry ना कर मैं
Welcome, sir, for the stage. And for this second live surgery, it would be from Ashutosh Hospital from Surat. So let's enter into the Ashutosh Hospital.
Hi, Rajiv. It is his speciality. Rajiv, can you hear us? Bolo, bolo. Very little.
Can you hear me now, sir?
Yeah, fairly well. Still, if it can improve a little better.
Volume बढ़ाइए. अबे सम्राट sir.
Yes, that's fine.
Better?
Yeah, we can hear you.
Okay. Can you see me as well?
Yeah, we can see your beautiful cap. The audience is appreciating the cap.
Thank you. Thank you, sir. I am going to show a theater, and then we'll go to the live surgery. I've done a drill already, which has been recorded, and the rest we will continue so that it doesn't waste time of the.
Can you show us the X-ray, Rajiv? X-ray we have not seen.
There's a video, you see. This is a level 30th, and he's a cook. So he said,
No, we are not getting the picture actually, Rajiv.
can you see the picture now?
So we are seeing the picture, but the conversation is not comprehensible. It's not comprehended properly.
Because we just do not know what is the problem. Because he is asking and he is demonstrating, but we cannot really understand.
Hello. 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 Sir, I think mic has to be replaced, sir. Your mic is not coming, voice is not coming clear. Tell your audio people to change your mic. It's cracking, sir. Yes, sir. Thank you, sir.
Can you hear me now? Is that better?
Sir,
Can you hear me, sir?
yes, we can hear you, but it's cracking. Can you? Now it's fine. It seems like fine.
It sounds better?
Yes, much better.
Okay, let's start.
Yes, sir. Thank you, sir.
Basically, he cannot overta roti banata. Something which would be akin to instability of the. So we can continue. So let the video, if you can hear.
Honestly, Rajiv, we just do not know anything about the patient. All this conversation is, as doctor mentioned, is not comprehensible.
इसका ऑडियो बंद कर दीजिए मैं बोल रहा हूँ ऑडियो बंद कर दीजिए હવે સંભળાય સર
The audio part is very mild. We can't really hear much at all.
स्टॉप कर दो, वीडियो स्टॉप कर दो, स्क्रीन चेंज कर दो. वीडियो को म्यूट कर दो, वीडियो का वॉल्यूम डाउन कर दो. यस.
So fundamentally this is the getting up from the chair test, and you can see that the right elbow is not being able to put pressure. it and the forearm, we try to supine it as much as possible. This is another test we will be doing. It is the table top push test. So he pushes the table in supination, and if you will see, he is not being able to push himself as much as he would want to. And finally, we will do anterior the drawers test. Now, if we see the drawer test is done with the patient lying down, the elbow flex, surgeon on the head end, and just have a look. Very good. That's one. So that's the full elbow and the raised head, subluxing.
बस ठीक है ठीक है कुछ लगेगा तो वॉल्यूम इसका थोड़ा कम कर देना
Now that is the elbow, that's the stretch field that we can see, and it shows opening on the lateral aspect on the X-ray that is on your right side. The gap has increased. The virus test is really alright. And finally, we will be having a look at the MRI scan. And in the MRI scan, we can see that there is a lot of fluid inside because of the instability element, synovitis, and the lateral ulnar collateral ligament is totally absent. So that is the MRI.
Now we can understand that. Yes, please. Are you going to reconstruct the LCL, or are you going to really do any of the tendon? It is how many months now after the injury? 4 to 5 months. So he came with the elbow dislocation? Did he come with the elbow dislocation? And reposition.
And sir, the scar which was shown, that is also part of the same injury. And what kind of a treatment for that wound was done at that point of time? Palmaris longus, you feel is too weak a tendon?
Tanna sir, I've done about 3 or 4 in last 3 years, and all the time I have used Palmaris longus for reconstructing. And first 2 cases, money also was an issue. The third one, it was an insurance patient, so I wasn't constrained. So I used Arthrex, and the whole surgery changes. You can just use the suture anchors, and that will push the graft in the tunnel, and you can use fiber tape as an internal brace. So that was half the time saved, and it's much stronger. That collagen forms around that.
Please proceed.
Sir, organizers were asking that we were taking too much of time. I suppose we can fast forward a few steps.
So we are marking up here, this is the part of the lateral epicondyle. That's the subcutaneous border of the ulna. That's the raised head. And this is the Cocker's incision. So this would go between the planes of the Antonius and the extensor carpi ulnaris.
Yeah, sir, from here, we would like to see the deep dissection also.
Yeah, now this is the, you can see that white line there, that is the interval between the extensor carpi ulnaris and the Antonius. You can very clearly see that the Antonius is a muscular belly as opposed to the
So, sir, you are now in the plane between the extensor carpi ulnaris and enconius. Towards the side is the enconius, and towards the side of your assistant is the extensor carpi ulnaris. Right, sir.
So the fracture that is anterior is impacting the extensor carpi ulnaris, the one I am trying to push through, and I am trying to approach the supinator crest from the ulna. Just for better refraction, I have gone a little proximal so that I can show it better. Now that part is the supracondylar ridge. And you can see some dirty tissue just near the knife where the refractor has come, that is the synovial hypertrophy.
Yes, sir, we can see it.
I'm exposing this part at this stage itself because I have to make my ulnar tunnel also proximally.
So the cartilage thing you are seeing is the distal end of the humerus.
Yes, that is the part of the tapestry.
Yes, sir.
This is the capsule that I have holding. We'll see the part of ulna very shortly.
So you are seeing the capitulum of the humerus, but we are not seeing the head of the radius in relation to it.
Yes. At the moment, since the arm is in 90 degrees of flexion, so there is some wire. So what you are seeing now is the radial head is anterior.
Okay.
My finger, left finger.
Right.
That's the radial head. And now you can see the supinator crest.
Yes, sir. We can.
Radial head is anterior.
Yes.
How do you see it?
Okay, sir.
The whole ligament reconstruction has to be posterior.
Yeah, it does not involve the head of the radius.
Sorry?
Yeah, the ligament has no attachment on the head of the radius, only a flimsy attachment.
That's right.
Right, sir.
It has to work like a sling. It's a supinator crest.
Yeah, I agree.
Your ligament has to be posterior to the radial head so that it works like a sling, preventing it from subluxing posterior.
Yes, sir. Well said.
And because the elbow is in 90 degree of flexion, this is virtually open
Yes, sir.
on the lateral side.
Right, sir. Yeah, I think we can fast forward now.
Yes, I'm fast forwarding.
Okay.
Here I'm drilling a hole in the supinator crest.
Sir, please explain the landmark which you are using to choose your point for making that hole.
Right. So I use two landmarks. One is the apex of the supinator crest. So stop it. So the distal hole, इसको pause कर दीजिए, ताकि मैं बात करूं. So I make a distal hole at the apex, just near the proximity of the crest, supinator crest, and the other hole
Yeah, and maybe anchor also will circumvent this difficulty. Right. Yes, sir. The point well taken.
In this particular case, normally I take a 3.2 millimeter drill bit because the boundary surface moves very smoothly through a 3.2 drill bit. But here I have to go for a 4 mm drill bit. The main reason being that I was apprehensive about everyone watching and me struggling.
That's right, sir.
So that is the thread that is being passed, and here you will see that I'm putting in a loop thread, negotiating the two holes. It is very easy to say that the diameter of your needle should be exactly equal to the distance between the two holes, but very difficult to get that.
Yes, sir.
Rajiv sir, can I give you a useful tip? You just keep your thread mouth at the point of entrance and connect good suction at the other end. That suction will just suck out your thread and bring it out wherever you want to bring it. We have tried it even in femur, patellas, everywhere. So it will work here also.
Thank you so much for a very lovely
Yes.
at all places.
I'm sure I'm clear.
I have put in a K-wire into the isometric point at the humerus.
Sir, please demonstrate the isometricity for the benefit of the audience, sir.
So basically, if you see the concentricity of the capitulum, then the central point of the capitulum is said to be isometric. Isometric means in flexion and in extension, it maintains the same distance.
Yes, sir.
That is where the ulnar, lateral ulnar collateral ligament is attached. Now, for that attachment, what we do is we are on the C arm. I make like a window, like a round hole of the lock nail. I would see that the part of the capitulum, the two epicondyles and the condyles, everything is overlapping on each other. And I take the center point of that circle, and that is the isometric point. Now, this isometric point is further confirmed by using this thread. So, once we have, before we put the tendon, before we make the hole, before we pass the tendon, we have made the ulnar tendon, and there is a thread that we have passed. So, what we do is,
Sir, the picture is frozen. We are just listening to you. We are not seeing any video.
that's it.
From here on, sir.
Are you seeing it in the Siam? We haven't recorded that. So I think if you people have understood it, take a lateral view of the elbow And in the lateral view, the elbow two condyles have to overlap. And in there, in the center of the lateral condyle is the isometric point. And that is the point which they takes it. Yes, Ashish, you want to say something?
Yes, sir. Perfect. We understood the point, but again, the video is frozen. So we could not see the demonstration of that. Okay, sir. Okay, then we take your statement for that. The basic point is that you have a thread, something which is not stretchable, wound around the 2 points, and then you make the elbow move the full range of it. If there is no change of the length, that means you have got the isometric point at both ends.
Raju sir, can he show the image intensifier image on the camera? It's not in the video, but can he show the stored image? That will make it clear. Yeah. One, and second, commonest error is that usually surgeons are behind. Yeah. So if you show the image, they will have a better idea. Yeah. Yes. Usually people make an error posteriorly. They are behind the actual isometric point. So here you are at the perfect bullseye. Yeah. That is the picture. Yeah. As you rightly said, it's like interlock hole, distal locking. Yeah.
Yeah, we now can fast forward. So if I get it right, now you have a palmaris longus tendon doubled. Okay, so you are going to single it, right? Yes, sir. Point well understood.
So that's part of the capsule that has been implicated with the teeth tissue. Yes, sir. Forward presentation. Forward. Next stage में जाएगा. Sorry, it's playing again and again. क्या हिंदी हिंदी कुछ तमिल में है राशि चलो बिल्कुल लगती है शांति यहाँ को दिखाओ इनको दिखाओ उन्हीं के चला
So we are now on the live part of the surgery. Right, sir.
Doesn't matter. So they can go and take. There is no formal tea break, but the tea has been kept outside, so all anybody who wants to go and take it, and please don't bring the tea in the hall.
So if you can see this part,
Sir, please reorient us again. Show us where the anconius is. Show us where the extensor carpi, where the tendon grafts is, and where are your sutures. Yes, sir. Yes, sir. Right, sir. Okay. Yes, sir. Yes, it's visible. Right, sir. Okay, sir. Right, sir. Yes, sir. We can see, sir. We can see it. Yes, sir. We can see that as well. Right, sir? Yes, sir. We can very well see that. Yes, sir. It is loop around the two holes. Yes, sir. We can see that shiny tissue of the tendon. Right, sir. These are both the strands now. Right, sir. Right, sir. Perfect. Yes, sir. Well understood. Okay, sir. So the one point which is not yet clear, the two tendons have gone into the hole on the capitulum. Where are the limbs coming out? How they are fixed? Right, sir. Right, sir. Yes, sir. Right, sir. Okay, sir. Right, sir. Okay. Yes, sir. Okay. One comes from front, one comes from behind, and both are tied together. Right, sir. Okay, sir. Understood, sir.
And after tying it, yeah, and after
Sir,
tying
I
it,
think you have two tunnels in the humerus. So, two tunnels in the humerus, and then you are tying onto the tunnel like a bone bridge, correct? You have a bone bridge on the humeral side, so that you are tying on the bone bridge. Yeah. Yes, yes, correct, yeah.
and after tying it up, have you checked up the stability of the elbow?
Okay, sir. Uh, right, sir. Very. Yes, sir. We all appreciate, sir.
Just for the sake of audience, I just want to add few points. Because nowadays we have anchors, interference screws, all are available from Arthrex, and internal brace is also available. So that can be used as an alternative also. I have been using those for a few years now. So this is another way of doing it, that is also another way of doing it, but it's expensive. That's the only point.
Right, sir.
Thank you, Rajiv. Very well executed. Thank you very much.
Thank you so much, Rajiv sir, for this insightful surgery. Uh, Now we request and look forward to the presence of Dr. R.M. Chandak sir to share his valuable inputs on the topic three-part fracture surgical neck.
Chandok is
Chandak,
gone for
sir?
coffee.
Oh,
He has
okay.
gone for coffee. So next person.
So here we end session 1. Now thanking Tanna sir and for Manoja sir for this valuable contribution for the moderator, and requesting Deepak Raina sir to join Chandramouli sir for the stage. Deepak Raina sir.
Deepak also
and-
looks like having gone out.
So panelists for this second session are going to be Dr. Tanna sir, Dr. Chandramouli sir, Dr. R.K. Manocha sir, Dr. Arun Mallu sir, Deepak Chakrabarti sir, Dr. Siddharth Gupta sir, Dr. Siddharth Patel sir, and Dr. Arun Lal KP sir. Would request our chairman for the session, Dr. B. Chandramouli sir, to set up the tone for the session.
Yeah, good evening everyone. So we'll proceed with the talk.
Yes, sir.
Okay. Yeah. So the first speaker for this session will be Mr. Dr. Sheikh, correct? Arun Mallu. We'll call Arun Mallu. No, here it is.
Okay, so the first panelist for the session would be Dr. Sheikh Mohammed Abid sir.
Yeah. So he will be
And the
talking on
topic would be distal humerus fracture.
fracture management. Okay.
Thank you, sir.
We request all the speakers to please speed up their presentations. They may only stick to the more relevant slides only. We are running short of time. The program is to finish by 6:30 and we are already very late. So I request all the speakers to please speed up their presentation. We wouldn't be giving, the first bell will go at 5 minutes. We'll ring the second bell at 8 minutes and nobody will be allowed to thereafter speak after 10 minutes. That's please, everybody please follow it.
Good afternoon, Chairman, moderators, and dear friends. Today I am going to present a case of comminuted distal humerus. So how it was treated, let us see. So 35 years old software engineer, he has come to the pain in the left elbow due to the history of fall in RTA. And he had no significant medical history and no significant other surgical history. So on clinical examination, there was diffuse swelling in the left elbow, and there were some abrasions and diffuse tenderness, and of course he couldn't move his elbow. And there was no distal neurovascular deficit. And so when the X-ray was taken, this was the view. Most of the times we can't take the proper AP or lateral view because the patient is in pain, so we can't go for true AP and lateral view. And anyhow we have to go for CT. So this is the CT taken. Here what we can see is a comminuted elbow, it's comminuted humerus with a lot of intra-articular fragments, almost like bag of bones, and a lot of comminution medially. Even laterally there is comminution, but more on the medial side. So on seeing the CT scan, that's what we found: intra-articular comminutions, butterfly fragment on the medial column, and even the lateral column wasn't intact. So now what are the ways we can manage? Number one, non-operative, or number two, with K-wires or screws. And if there is a lot of swelling, we can go for fixation. And once the swelling subsides, when the storm subsides, we can go for fixation. And of course, last is plating with 1990 or 180, whatever it is. I think in this 2022, many of you will be going for plating. No, I don't think anyone will be going for the conservative treatment. Previously, there were many papers that is in olden times, but the results were very bad with the non-operative and minimally invasive techniques. So now coming to plating. So we have two methods. One is 1990, that is posterolateral plating and medial plate. Another is 180 degrees, that is lateral and medial plating. There were many studies comparing, but in long term, I think almost the results were same in both the plating, both the methods. And what is the advantage of lock fixing fixed angle plates compared to traditional recon plates? In lock fixed plates, we have many small screws, whereas in recon plates, especially when the distal fragment is very small, I don't think can go for many screws with a normal recon plate. And so, now once we have planned for surgery, what is the approach we are going to take? This is 13 means distal humerus, C means total intra-articular, 3 means the articular surface is very much comminuted. So 13C3. So different methods are triceps splitting approach, triceps sparing approach, and olecranon osteotomy. In type B and A, we can go for triceps splitting or triceps sparing approach, but this type C, so you have a lot of intercommunication. I think you need to visualize the joint. So we preferred going for olecranon osteotomy. So what we did was, we planned to do the fixation in a lateral position, posterior approach with olecranon osteotomy, and 90-90 plating. And once the surgery was finished, we went for TBW. So here you can see the intraoperative photos. First, we reduce the articular surface. This is the main part. You see that the articular congruity is maintained. Once you have reduced the articular congruity, you have maintained the articular surface, the half surgery is done. So now next part is you try to reduce you try to fix the less committed part. So in this case, it was the lateral column. So we fixed the lateral column, and then first we fixed them temporarily with the KYs, and then we had gone for plating. And this is the post-op X-ray. So the main thing is you have to maintain the 3 columns. This articular column, lateral column, and the medial column. And this is the post-operative after 3 to 4 months. And the thing is, we had to at least get a decent range of movements at this 30 to 120 degrees. That is a functional position, functional movement. Thank you.
Yes, any comments from audience, please? Anyone? Right, show that last X-ray, please. So, do you think that the olecranon osteotomy is not causing you any trouble?
I think more compression should have been in this.
Pardon?
More compression should have been there, sir.
Yeah, I guess so. Otherwise, I think you have done an excellent job. Your reconstruction of the column is good. Your reconstruction of the articular surfaces is good. But my only concern remains that possibly this olecranon osteotomy is going to give you a problem. Anyhow, with this kind of fixation also, range of motion cannot be any better than what you have already achieved. Any more comments from any of the? Thank you very much. Thank you, Rasul.
So we'll call upon the next speaker, Dr. Deepak Chakrabarti. He will be speaking on distal humerus non-uniform fracture.
Good evening, everyone.
So, while we are setting up the presentation, can we have a raise of hand how many people use a trap and how many people olecranon osteotomy for a fracture like this? The trap first. No, everybody will use an olecranon osteotomy, right? And that makes sense. My personal indication for using an olecranon osteotomy is only when you have a separate fragment, which has articular fragment which is separated either from the medial as well as the lateral column. If that fragment, if in central fragment, if there are only two fragments, one is with the lateral column, one with the medial column, you can easily manage with trap. But if you are having a separate fragment, which is the third one in between, you have to go for olecranon osteotomy. Yeah, please, doctor, start.
Good evening, yeah. Thank you, Meryl, for getting us all here, and I'm very privileged to be speaking in front of such great doctors. My name is Dr. Deep. I'm presently working in ESI Shialda, Kolkata. If you may please give me permission, I will be speaking about distal third humerus fracture, not intra-articular fractures,
go ahead.
if you don't mind, sir.
Yeah, sir.
Okay. Coming to the history, this is a female patient, 39 years old. She had a fall from a two-storied building. She sustained injury to bilateral humerus distal third. Only one background problem that you have is like she had an episode of epilepsy. She was not on any regular medication. So that's a concern. So these are the images. I'm extremely sorry, the screen is little off. Okay. So how many of you would eventually think of doing a conservative or a operative? So we wouldn't be here if you are thinking about conservative, right?
So would anybody treat with this fracture by conservative methods? So there's no, so everybody
really.
goes for operation.
Everybody goes for operation. Just we'll speak about the right one, but just a short introduction about the left one. This is how the left humerus was operated. Simple plating, good compression. Okay, the date was 30th of September. Now coming to the follow-ups. So this is Jan. Are we concerned? Can we see the fracture not uniting? Are we concerned? It's three plus months now. We are
Yes,
concerned,
anybody?
isn't it?
Yes.
I'm totally missing Dr. Tanna here. You would specifically say no, wait till 10 months, 12 months. Yes, but the index surgeon, that was not us, index surgeon did go ahead and do a bone marrow aspirate and put it there. And eventually it seemed like it united in due course of time in July. Excellent result, isn't it? The same story doesn't hold true for the right side. So this is how the right humerus was taken into consideration. It was started to be treated conservatively. Although the varus and the axis looks okay, but there is too much of fracture gap. And anyone happy about it? Should we continue? This is exactly at the index injury. I don't think so. But still, primary surgeon went ahead,
Excuse me.
waited.
If somebody wants to conserve it, better to apply extension cast.
Extension, exactly,
With
sir.
a
Exactly,
necklace
sir.
collar.
Exactly, sir.
Yeah, this
I
is
totally agree with your point.
This is called the hanging cast.
Hanging
the hanging
coefficient
cast puts
blins.
a weight
Exactly.
and causes this kind of distraction.
So we learned something from here, didn't we? So this is how it progresses. So this is now December, already 3 months. Not happy, are we?
But still the hanging cast continues.
Still again, the cast remained. The same flexion cast remained for 3 months. And see, we are having distraction, there hardly some callus. This is now Jan. This is when the time when the left hand was given a bone marrow aspirate, the primary surgeon thought of going ahead and plating. Are we happy? It's extra articular plate of the right humerus. We are happy, right? Yeah, we are happy. Now comes the trouble. Patient starts developing pustular discharge from 25th of Feb. But initially, I'll be very sorry, there are a lot of labs in our country. Good laboratory workup is not done. So index culture and sensitivity report were negative. Only until June, only one report I found that shows scanty growth of Staph aureus. And accordingly, the primary surgeons, they went ahead and did a variety of miracle doing linezolid, some short course of rifampicin, and etc. Other antibiotics were going. So now it is established as a non-union. Now these are the non-union diagnostic workup. I won't bother you with all these things, but I would specifically say always go ahead and do a vitamin D checkup for female patients. Indian females are very poor with vitamin D. Biologically enriching them would definitely help you in a non-union, in not infective scenario, in non-infective scenario. So this is how the access finally progresses. Now the index surgery was in Jan. Now this is March.
Discharge is still continuing.
Exactly, sir. Discharge is some sort of discharge. By this time, the multiple cultures were taken. None of them were conclusively growing any pathogen. So we are fully confirmed that this is an infective kind of non-union, and we have to plan it accordingly. This is in July. Not until that time the patient has presented to us. Now, what are the treatment options we have? We have revision surgery, 1 stage versus 2 stage. 2 stage is always preferable, in which we think about mascule. Elizar or distracting osteogenesis is one of the very good option, and there are other reliable options. Allograft and titanium cages are hardly available in our setup, so let's just cancel about it. Patient presented to us in September 2021. She was having persistent discharge. We also got in the culture. Unfortunately, we didn't get any. So we admitted her in October, tried to do a implant removal, stage 1. But unfortunately, we failed. See, this is one very important point. If we are not prepared for the implant removal, we could just knock off 2 of the proximal screws, and other screws still remained. So we went ahead and just debride all the non-necrotic tissues, non-viable bone, and put a stimulant there to see if at least we can control the infection and just wait it out.
Stimulant loaded with antibiotics.
Exactly, sir.
Which antibiotic?
Sir, we used vancomycin. Yes, it was the July culture was positive for vancomycin, so we went ahead and vancomycin. So okay, next time we gave 3 months of breathing time for this stimulant to work. But unfortunately, if anyone has used stimulant in such a bad wound, you'll see some sort of whitish discharge always coming, pouring out. So even though after stitch removal it was okay, but till January she was showing some signs of discharge. It was totally sterile. There was no culture growth in it. In January, we finally decided we'll go ahead. We are fully planned. We got this very small set. Always remember to have this kind of set with you when you're thinking about implant removal. And it really helped us. We finally got the implant out. So after getting the implant out, our exact plan was to go ahead and think about mascule. And these are the there are 2 stages of mascule. Please hear them out. The first stage being debridement. Debridement is the cornerstone of any masculine surgery. Any debridement you do, we have to think about all the bones. We have to see the good bleeders. We have to preserve the neurovascular bundles. Using a PMMA spacer is a cornerstone. Although the index surgeon, Dr. Mascole, always advised to not use a antibiotic-loaded cement. But yes, we have been using antibiotic-loaded cement throughout. And we have to fix that cement in such a way, either do internal fixation, either external fixation. But in this kind of scenario, we were totally very scared. Putting even a single metal pin inside might flare up the infection again. So we abandoned everything, just put a spacer, and we just left it out. The second stage of mascule is we have to close it with bone graft between 4 and 8 weeks. So this is how a mascular technique works. Whatever the gap is, mold the cement, go 1 centimeter proximal, 1 centimeter distal, cover the entire circumference of the bone, so when the inducing membrane forms, it should cover up it completely. We also added some stimulant against the small beads. We are very scared about this infection, just doesn't seem to go. Again, this is the problem. We didn't fix with any pin externally, neither did we pin internally. She still had some sort of clinical discharge. Again, non-purulent. Now comes my partner in crime, Dr. Prasenjit. He's sitting here. One fine day, he's sitting in his home, no wife to disturb him. He's doing his routine activities. He suddenly thinks from his residency days, yes, my professor told me this kind of infection can be non-tuberculous organism. He's immediately started rifampicin 450 was started OD, and we actually continued for 80 days. And sir, to be very, on the clinical perspective, we saw the discharge and the wound to granulate well. Now we are happy. Now, usually the second stage of mascule should be done between 6 to 8 weeks, but we actually made it a little late. It was not until 9th week we could finish it. So this is what we did at the final April. We did an LRS. We re-debribed everything. We took a tricortical electrocrest bone graft. We also put some elugrine beta tricalcium phosphate. Finally, we are happy with some into the soft tissue. And finally, we are happy. Now, these are the results of this female. I'll just show this short video. Now, this is 3 months now, sir. Now, I'm very confused what to do next. Should I remove the LRS and go ahead with the internal fixation, or let the LRS stay? This is my question. So our learning points are a good index surgery is very important. Okay, appropriate antibiotic profile. You don't keep changing it. Okay, give it enough duration of the antibiotic to help. Call for help whenever you cannot be a god. Whenever you need help, call for senior colleagues. You're not understanding. You don't know what to plan. Call for help. Mascule may fail. There are evidences saying them once mascule can fail. If mascule fails, go ahead, redebride, put a spacer again. If it fails, go again, do it. But only thing is the cost constraint and the patients are not happy with it. But yes, principles should be kept in mind. And please wait and watch. Don't go ahead and jump and go do an intervention at the first stage. Thank you very much for patience.
And also, do not apply a hanging cast to the humerus.
Do not apply hanging cast, rightfully said, sir.
Right, thank you, doctor. Any comments from the audience? It was a good case which should arouse some discussion. Yes, sir.
Sir, final X-ray, sir, she is just 2.5 months now. This is how we had actually in the post-op scenario. This is a post-op, sir. Recent X-rays are still awaited, sir. In government setup, they don't come so easily. Don't come so easily.
Right. Yes, another one.
Question. You have used stimulant twice, and the first setting probably you have used a paste, not beads.
No, we use beads. The X-ray is not very
so
clear.
how much stimulant and how much vancomycin?
We use 4 grams of vancomycin.
How much stimulant and how much vancomycin?
I think it was 5 or 10 cc stimulant. According to the recommendation,
there is no recommendation as such. You think it was 5 or 10? You don't remember?
It was bigger beads.
Because you would add adequate amount of vancomycin.
Exactly. Yes, stimulant has a recommendation, sir. For 5 cc, you put so much vancomycin. Either put gentamicin or.
They don't mention any quantity as such, but.
Yes, we go.
Yeah, they do mention.
Yeah, they give a parchi. On the top of the either 1 gram or 2 grams. Sometimes, the more you eat, the more antibiotic you mix, the more time it takes to set.
Timing is a recommendation, yes, but how much quantity?
No, quantity also is defined.
How much vancomycin did you use?
For 5 cc of stimulant, there is a recommendation. I'm very sorry to tell you. I think it should be 1 gram.
Yeah,
No,
it is.
Right,
for
it is
5
little more,
cc.
but if you are greedy and you mix more, it just doesn't form balls.
It doesn't form the paste,
a
and
mess.
it just becomes a paste.
That's it, yeah.
We didn't put a paste. We formed proper beads and we applied it there. 1 gram for 5. Thank you, Dr. Kunal.
Excuse me,
The
you said,
antibiotic can take almost 45 minutes. So now if we are going to use that, we prepare it even before starting the case. We know that we are going to use it. Otherwise, if
Absolutely,
you do
sir.
it at the end, 1 hour you are just sitting doing time pass.
Absolutely,
Wasting time.
you said previous cultures was negative.
Yes,
Only
sir.
once in a while you get stay up for years.
Only for few, very scanty growth. So appropriately, whatever antibiotic was reasonable, the primary surgeon thought it deemed necessary. They kept prescribing her. She had 7 days, some antibiotic for 14 days, but the discharge never really stopped. That's what the history
Is
says.
this the samples of discharge only or tissue culture was taken?
Because sir, the wound that I showed you, I'll just go back. She has been mentioning that she had this kind of wound throughout from the index time. Now it's very difficult to go deep.
Have you ever tried tissue culture?
Sir, during our first stage when we removed the plate, when we were trying to remove the plate, yes sir, we did. But by that time, so much loading of antibiotic was there, and our lab, per se to say, is not very good.
We cannot keep on this two-way discussion. Just make your comment, listen to his answer, and that's what we have to.
Never got a conclusive microorganism, sir.
He
That's
did what he thought was best. Right. Your
Sir,
comment.
can you come to the last X-ray of LRS?
And we conclude your case with this comment.
Yes, sir. So what is that in the fracture side?
This is a tricortical iliac graft. We also gave allogren, beta tricalcium phosphate.
But you are putting
matrix
an
enhancer.
LRS, so why do you need a tricortical graft there? You have 2 flat surfaces, just compress it and put a
It would have
corticosteroid.
shortened, isn't it,
Yes,
sir?
it will shorten.
It would, but we
But
wanted
now
to maintain the length.
No, but it does not have a very flat surfaces to unite. You are taking off 1 surface and now putting 4 surfaces there to unite.
Okay, you made your point. So he chose to put on a tricortical graft. Right.
So one couple of comments. Stimulant does give an Excel sheet. They give a proper Excel sheet. 10 cc gives 2 grams of
2
vanco.
grams, yes.
You cannot use more than that. And
Should
45 minutes is only with meropenem. Vancomycin sets in 3 minutes. So they have a very beautiful Excel sheet. A second, I think the rifampicin worked against your staphylococcus. rifampicin generally doesn't work against NTM. So that's where it worked in your case.
Right. Thank you. Thank you. Thank you, doctor. Please, sir, next.
So we'll thank Dr. Deepak for an excellent discussion.
It was a good case to be presented. Thank you. A clap for him.
Our next panelist is Dr. Siddharth Gupta, sir, who will be presenting on the topic distal humerus intra-articular fractures. Requesting Siddharth Gupta, sir.
So yes, coming to that point, whether shortening should be accepted in a humerus or you can add a tricortical graft. So who would in this sort of a situation with that much of a gap would choose to add a tricortical graft in an infected situation, and who would rather shorten the humerus? Raise of hand. Please shorten the humerus first. And okay, then we see the majority. So in an infected non-union, a shortening of that much in an upper limb should not be a concern. Putting in a tricortical graft adds up only another incision at another point and makes that cortical graft also threatened by the infection. Right, thank you. Yes, please.
Good evening, everyone. I'm Dr. Siddharth Gupta. I'm from Kolkata, West Bengal. This is a very interesting case which I got 1.5 years back. I really did not find any history in such cases. There was only in 1994, there was a non-union fracture humerus with malunion fracture, intra-articular fractures in JBCH paper published. So it's a very interesting case. So this is a 35 years old male patient met with an RTA. It was his right dominant distal humerus intra-articular fracture over a non-union distal humerus fracture. And this non-union was about more than a year back. So he had no surgical or medical comorbidity. This was his preoperative images. So it's a very interesting case. So my concerns were this humerus non-union. Over the top there was an intra-articular fractures. Which approaches, what implants, should bone grafting be there or not? So what options do we have? Anyone? We can go for long pillar plates with or without bone grafting after debridement of the fibrous tissues. A pillar plate with an extra-articular plate, long plate with or without bone grafting, or pillar plate along with DCP and bone grafting, or an antegrade nail along with a pillar plates with or without bone grafting. And the intra-articular obviously should be managed by olecranon osteotomy as we had discussed previously with intra-articular screws. We can go on. So what was my technique in this case? It's a very interesting case. So what I did is opened it posteriorly, did an olecranon osteotomy, freshened the fracture non-union part, fibrous tissue, put a retrograde nail from the fracture side, and intra-articular was fixed by CC screws, and then bipillar plate without a use of bone graft. So this was his post-operative X-rays.
Dr. Tanna sir, your comments.
For a shaft fracture, this is too unstable. I would have extended the plate way high up on the lateral side.
So I have added a nail.
Now the nail is only one nail at this sort of a situation, I feel is not enough.
So that point is proper. So let us see what happened to this.
So this was after 12 weeks. And this is after 28 weeks. Okay. It's united well, and this is his range of motion. just a 5-degree lag, and it's almost 120 to 130 degree range of motion. Early mobilization of the fracture, what we did, and this was the case.
Yeah, unusual case, you got good result, but Dr. Tanna's point, having a plate ended at a site of non-union.
We did not open the fracture at
So
all.
what, that does not matter.
We did not open more proximally.
That
We just-
does not matter.
Does not matter.
You cannot have a plate ending at the site of a non-union fixed with a nail which is so thinner compared to the intramedullary dimensions.
Any non-union fracture need absolute stabilization.
I agree.
That's what I'll come to the
Particularly
additional information.
Particularly the hypertrophic one.
Yeah. I'll come out with the additional information. So hypertrophic non-unions, bone ends are sclerosed for more than 6 months, which what thing is. But if there's an hypertrophic non-union, there's already a vascularity, and the problem is stability, which is lacking, or normal axial alignment is not restored. It is important to make a point, lot of times even a classical hypertrophy non-union can have loss of vascularity also. So a non-union resulting with a mechanical problem with poor fixation or reduction as well as possibly diminished vascularity can be a concern sometimes. So for me it was a very interesting case. So all the intra-articular fractures of distal humerus should be treated with an olecranon osteotomy, find the fracture fragment, stabilize it with a plate for better reduction, and when stability and good axial alignment is there, hypertrophic non-union usually heals with a relative short span of time.
Okay, with your last comment, can you go back to your X-ray? So the previous one. Do you think that this is a good axial alignment?
There is a bit of, but
do you think this nail thickness is good enough, or is the nail sitting eccentric at the site of non-union?
Yes, nail is sitting eccentric.
So, see, the fractures can unite despite the surgeons as well. But if going by the science of the surgery, this is not adequately scientific, right? Okay, but you got good results. Congratulations to you and to your patient.
Just a final question, sir. A very good result finally, but consider you just have a hypertrophic non-union of shaft and nothing else. Will you just put a nail?
No, we have to stabilize it and also freshen the fracture fragment.
But will you use this nail in just a
No,
humerus?
this is a different case altogether. Why will I put this nail? A bigger size nail can be put even after, if I opening the fracture fragment from way large exposure, I'll put a plate. Why to put a nail?
That is the
That
issue
is
of
the
stability, sir.
Yeah.
So in this case, ideally, we should consider both the situations totally different, and both needs and different stability. So if it is isolated shaft, hypertrophic non-union, you will not just prefer this nail.
Absolutely.
So why you have preferred here?
You made your point. Any other comments?
Sir, so in case after the fixation, sir, if in case it again goes to non-union, if in case it at all goes to non-union again, then how you would remove the nail again? You have to.
This is a nice question, very hypothetical situation, but it's a very nice question.
Like sir, in this situation where
there
are high chances of it's going to non-union again, sir.
No, it's already united. First of all, this case.
Sir, if it is united also, if you need to take it out, how will you take out?
So, see, there are ways to take out the nail. The nail can be a cannulated nail. This is a cannulated nail. You can take out the screws and put a guide wire from anterior grade, and with there are ways to take it out.
Okay, it would be difficult. Yes,
But it is a
admitting
difficult
that.
process.
Next, yeah, next.
Hi, in a hypertrophic non-union, in a long bone, can we not use nail? That's what was the message given by other faculty.
No, that's not the message.
That's not the
so
message.
in this case, when there is a hypertrophic non-union.
So the nail expert, Dr. Tanna, will explain.
Yes, sir.
If
Please,
the
sir.
nailing is to be done for a hypertrophic non-union, what he would do? Please, sir. And thicker nail, your choice for a thicker nail which fills up the cavity, which fills up the medullary cavity. Yes, sir. That's the point, or a hypertrophic non-union. He adds a plate also for such an unstable situation, that's fine. And you were already adding a plate right there. and you still chose to keep it down. That's not acceptable.
No, no,
And
I did
you
not
had
have
to,
a bigger plate in there.
You
I
had
did.
to have,
Yeah.
you had to have the nail also a thicker one.
Yeah, absolutely.
So, okay, right.
So,
Thank
so,
you.
So generally, sir, when we are doing a hypertrophic non-union, we generally want to put a over rim and put a thicker nail. Thicker nail. But sir, is that what it is that the plate is must? Because in a hypertrophic union, the body is trying to unite. It's not that it is not. So it just needs stability.
Yes, sir.
And stability with a locking nail all up and down.
Okay, please listen
In
to
an
Dr.
isthmus fracture,
Yes, sir.
where the nail is holding very well 2-3 inches above and below, you don't need any adjuvant. But in a fracture where the whole
Canal is
thing is
bigger.
expanded, so at junctional level, or here which is also, as you can see, the nail is not doing much. He is very lucky that even in spite of the fact the nail is there and there is a mal position, it has held up, so that's very good. But in an isthmus fracture, you don't need any plate.
Yes, sir.
But in a lower down fracture, you need the subjoint.
Yes, sir. Thank you.
Okay, right. Thank you, doctor. Thank you. A good case for presentation. Thank you very much. Sir, next. Please call the next speaker.
So now we will invite Dr. Arun Lal sir to present his thought on the topic management of complex distal humerus fracture.
Good evening, everyone. This is basically it's not a true case presentation, and I'm from Calicut, Kerala, and it's a case presentation series basically on supracondylar intercondylar fractures of the humerus. So the first case, it's a 33-year-old male met with a road traffic accident, complaining of pain, swelling, and deformity of the right elbow without any distal neurovascular deficits. So he was initially treated in a nearby hospital, and from where this X-ray was taken. As you all know, this X-ray won't provide you any information regarding the fracture. So what next can be done? You can either do a three-dimensional CT, or you can take a traction view on table. This is an on-table traction view, which helps us to delineate the fractures there. I've taken a 3D CT also. So that is a 3D CT. So how to manage this? So brief discussion on this management of supracondylar fractures with intra-articular extension. Non-operative treatment, it's very rarely indicated unless it's indicated only for patients at very high risk for anesthesia or in frail and low demanding patients. Operative treatment is the treatment of choice, which the goals are to restore the joint integrity, to enable joint stability for a functional rehabilitation. K-wire fixation, percutaneous screws, both won't provide adequate stability, so they are not recommended. And ORA, for open reduction and internal fixation, is the treatment of choice. And early total care, early establishment of exercise stable conditions, and early functional rehabilitation gives good functional outcomes and reduces the complications. So what approach? There was a discussion on the approaches. So all of you agree that the dorsal approach is the best approach for a type C fracture, where the entire joint can be exposed. Depending on how the triceps is handled, you can have a muscle splitting or triceps splitting approach. The triceps can be pushed to the side like trap, or the triceps reflecting approach. It can be removed by the osteotomy of olecranon, or you can maintain the triceps attachment by the paratricepital approach or para-olecranon approach, which I use the most. What type of plate, how many plate, and what configuration? There were 3.5 mm straight standard plates, which were intraoperatively contoured, pre-contoured plates, both in parallel or perpendicular configuration, Y plates, or 1/3 tubular plates, which are too weak and prone to breakage. Pre-contoured plates are anatomic. They have superior biomechanical properties, and they helps in high density screw placement in the distal humeral attachment. Good fixation requires two plates, parallel or perpendicular, The perpendicular plate was recommended or introduced by Jupiter in 1985, and parallel plating was introduced in 2005 by the Mayo Group. Triple plating, it's a combination of both, which is technically difficult. There is no major advantage. There were so many studies comparing all these situations. Another plating is Y plating, where it's of use when there is a diaphyseal component. So there are several biomechanical studies comparing all these, but clinical studies, those are basically two studies, one in 2013 by Lee, which in both the studies, and the other one is by Shin et al. In 2010. There is no major significance with respect to clinical outcomes in these two plate configuration. How to fix? For C1 or C2 fracture, that's a type C fracture, we can convert into type A, that is the intra-articular fracture reduction is done first, then we go for final fixation. Or you can convert it to a type B, that is a partial articular fracture, and then you can proceed to the final fixation. So basic goal in C3 fractures, it's a realignment of trochlea to its original width, and inherent stability of the elbow is enhanced by that. You can use headless screws for small fragments. And if there is any bone loss, you can go for a supracondylar shortening or bone grafting. The classic AO recommends, the classic AO technique is you fix the articular fragments first, followed by orthogonal plate fixations. Whereas the Mayo Group, they recommend maximizing fixation in the distal fragments, and they ensure that all fixation of the distal fragment contributes to stability of the supracondylar level. So my case, coming back to my case, what should I do here? I plan for an open reduction interval fixation by para-olecranon approach. I plan for an articular reduction first, interfragmentary compression, bicolumnar perpendicular plating, and pre-conduit plates. So this is basically the para-olecranon approach, where the central part of the triceps tendon is maintained, and that is a lateral column which is visible, and I fix the lateral column, and you can see the ulnar nerve and the medial plate is there. So that is the intraoperative C-arm images, the postoperative X-ray. And regarding the postoperative rehabilitation, active ROM exercises are started within 48 hours. And ROM exercises to tolerate, to the tolerable limits of plane. And gradual improvement is expected in 4 to 6 weeks. So this is 1 year follow-up. So that is the complete functional outcome. As case number 2, 33-year-old female, road traffic accident, closed injury, no distal neurovascular deficits. Again, para-olecranon approach. So that is a reduction using pointed reduction clamps and KYs. That is a lateral plating. And the medial side, I use the compression device. And the compression is given, and then positional screw is given through the plate. So that is the final fixation on the lateral side, and progresses to the medial side. This is the immediate post-operative X-ray. This is the 2 months post-op. That is a functional outcome at 2 months, and this is the functional outcome at 5 months. The fracture is united. This case number 3. This is a 65-year-old female, slip and fall at home, injury to right elbow. That is a CT scan. Again, para-olecranon approach. So after fixation, I usually take the elbow to the full range of motion on table itself to assess the stability of my fixation. So those are the post-operative X-rays. 8 months follow-up. That is a functional outcome at 8 months. Case number 4. This is an 83-year-old female, fall at home, closed injury, 3D CT. That is a fixation. Same compression device was applied, and those are the positional screws through the plate. Immediate post-operative X-ray. There's only 2 months follow-up there, but she gives the functional outcome was good at 2 months. She didn't turn up after that. Case number 5, 64-year-old female, slip and fall at home. Same approach, para-olecranon approach. Post-operative, immediate post-operative X-ray. This is a 2-year follow-up, complete range of motion. Case number 6, 43-year-old female, male, fall from height. Here I have used an olecranon osteotomy because there was too much comminution intra-articularly. So that is the articular reduction and final fixation. That's a 6 months follow-up. I don't have a clinical image on that. So take-home message, distal humerus fracture treatment continues to improve Pre-contoured plates have revolutionized the fracture care, but there should be a careful pre-operative planning. You have to follow the principles, and the surgical plan must be executed precisely. Thank you.
Good cases, very good. Any comments, please?
Thank you, sir.
Very good cases, sir. Just a question.
Yeah.
How many times do you need to bend the pre-contoured plates?
I don't bend the pre-contoured plates, which are all pre-contoured.
Okay. Because it's again the same question. One size never fits all. So sometimes.
Because all those are LCPs, so I don't means like it's not needed that you should approximate the plate onto the bone.
About that question, I find that most stainless steel plate from Indian companies, they are pretty stiff. If it's a good quality titanium plate, either one which we are familiar with, or from good Indian companies also, titanium plate, even if there is a small gap, it just takes the shape of the bone rather than deforming the bone if your fixation is methodically planned and executed, is proper. I would like to know that quite a few of your cases there was intra-articular extension without comminution, of course,
Yes, sir.
but still you could manage without an osteotomy.
Yes, sir.
On few occasions when I tried to do that,
Yes, sir.
finally I was fed up. It's too much of a hassle and I'm not really getting it perfect. So most of your x-rays, they were showing good reduction.
Yes, sir.
So can you enlighten us about how
So
do you...
the approach I go is by the para-olecranon approach, where the central part of tendon is, central part of the triceps tendon is kept intact. I reflect the lateral portion along with the ancones. It's basically a modification of the trap approach. It was more commonly used in the Japanese area. And the medial side, I go very medial. Initially, I will expose the ulnar nerve, isolate it, and I reflect the medial part from the medial intermuscular septum. So I get a good view of the lateral column along with the trochlea and the medial side also.
So we all understand what paratricipital is. Now you're telling us para-olecranon. That means that the lateral and the medial side, which is an incision you are making, a deep dissection is going right across on the sides of the olecranon.
Yes.
Yeah, that's what you are doing.
Yes, sir.
Yeah, I can understand that way your access to the capitular part will be good because it's all just a radius which is sitting on it and the rest of the thing is.
Yes, sir.
His point is
Yes.
that how do you gain that access or the hidden part of the trochlea?
Yes, that central tendon, I mean, my incision goes just adjacent to the olecranon. So from the sides, if you look, you can see the trochlea also from there.
Good.
So if the trochlea is too much comminuted, I would go for a olecranon osteotomy. Okay. That's my point.
Right. So I have also one question. So I saw that you have been using that lateral plates with a post.
Yes.
I have a little bit problem with this post. They always become very prominent and the patient keeps on troubling me.
If you go back to my X-rays or my clinical listing, I don't see anything.
So what is your trick to not have that problem?
No, I keep it on. I properly take off the soft tissues from the lateral side, keep the plate very adjacent to the bone, and I always use a template.
Olecranon osteotomy, which makes the life very simple for an intra-articular fracture.
Yes, sir.
I understand you feel that olecranon osteotomy has its own hazards.
Yes, sir.
But olecranon osteotomy done properly, when you see after olecranon osteotomy, when you see the two parts of the humerus
Yes, sir.
from the front, but when you bend it, you realize that it is not in the alignment.
Yes, sir.
Because it's a circular fracture there. And that's the reason why quite often, even after olecranon osteotomy, if you don't bend it and see at the back, you remain ignorant about it.
Yes,
While olecranon osteotomy allows you to do that, to get that 100% reduction there.
Correct.
And the non-union rate of an olecranon osteotomy is almost negligible if you are treating them by a tension band wire.
Yes, sir. Point taken, sir.
Even those one or two patients where I felt that it's delayed union, did not do anything, and patient also did not succumb because he was asymptomatic, and finally it united. Sir, about that flange thing, I spend really hard time and make sure that my wires are placed first most of the times I will be passing a screw through the flange so that it abuts against the bone. Otherwise, it's nightmarish. If it goes on hurting, he will trouble you, in spite of a good out. So that one screw in the flange goes and pushes it against the bone at some stage.
So here, how many times you have done ulnar nerve transposition?
I haven't done so.
Never.
Before.
Yeah, yeah. It's earlier in traditional teaching, it used to be advised that you transfer ulnar nerve. Now most of us have stopped doing ulnar nerve transposition because of the pre-contoured plates.
Yes.
Thank you, doctor. That
Thank
was
you,
a
sir.
good presentation.
Thank
Thank you.
Thank you, Dr. Arunlal, sir, for this wonderful presentation. Now we request Dr. Siddharth Patel, sir, Dr. Siddharth Patel to take the stage and present the topic, Management of Complex Distal Humerus and Shaft Fracture.
Good evening, friends. I'm Dr. Siddharth Patel. I belong from Vapi, so a very warm welcome to my humble town. It's known for pollution and Merrill, so I hope you are at the better part of Vapi.
We had the taste of both.
Yeah.
We had the taste of
So I apologize for the pollution, and rain gods have been kind enough on us because there was heavy rains in the past week. My topic is actually my topic was fixed before I could do the live surgery. So I'm lucky enough to actually get a case on what I'm going to present. Anterior bridge plate MIPO for humerus shaft fractures. I work here in a small setup at Ashirwad Hospital. It's a very small, humble setup. Case 1, 27-year-old male, history of road traffic accident, left middle third combinated humerus fracture, AO type 1 to B3 with left rib fracture, had no pneumothorax. That's the pre-operative X-ray. Surgical options that we had was ORIF plating via posterior approach, concern, reduction in view of butterfly fragment, and of course the radial nerve. Intermedullary interlock nail, concern is the shoulder entry, smaller medullary canal in some cases, and distally sometimes the length of the nail is an issue. Close reduction Enders nails or a titanium elastic nail, concern is again stability and reduction. ORIF with an anterolateral approach, concern is this anterior scar, as sir mentioned when I was doing the live surgery for the anterior approach, and of course the brachialis muscle injury. Anterior bridge plate via MIPO, concern is the technique, radial and musculocutaneous nerve, and the reduction. We chose anterior plate because I'm presenting now. Patient is positioned in supine with arm to 60 to 90 degrees abduction. Forearm is fully supinated. Surgeon sits on the lateral side. Image intensifies from the opposite side. Proximal incision is interval between the lateral border of proximal part of bicep and the medial border of deltoid. That's a diagrammatic presentation. Distal incision is around 3 centimeter to 5 centimeter proximal to the flexion crease of elbow. Around 3 centimeter distal incision, interval between biceps brachii and brachialis is identified. Radial nerve lies posterior to brachialis, between brachialis and brachioradialis, laterally to the brachialis. Forearm must be kept fully supinated because when you supinate, the radial nerve moves away. Biceps is then retracted medially to expose the musculocutaneous nerve on the anterior surface of brachialis. Brachialis split longitudinally, and then we are on the anterior surface of the distal humerus. Musculocutaneous nerve is retracted along the medial half of the brachialis. Crux is you use a right angle retractor. Lateral half provides cushion to the radial nerve and is retracted. Some surgeons do mention to actually identify the radial nerve. I don't do that. That's a diagrammatic presentation. Then we do a subbrachial tunnel by the tunneling instrument, as we do it from distal to proximal. Then we pass the plate. To avoid nerve injury, do not use Hohmann retractors. Medially you can, but it's better to avoid. musculocutaneous nerve has to be identified before splitting the brachialis to ensure the nerve will be retracted with medial half of brachialis. In the middle part of the humerus, bicortical drilling and screw fixation from anterior to posterior has high risk of radial nerve injury. So if in midshaft area it needs fixation, screw should be applied monocortical wherever possible. So that's where. So that's the incision, musculocutaneous nerve. The position in this picture as well, you can see my assistant is tightening two screws together. That's where you get the lateral reduction. And I am correcting the varus valgus, whereas my staff nurse is giving a good traction to get the alignment right. This is the immediate post-op X-ray, 6 months post-op X-ray, clinical results. Patient has no complaints. Second case, 37-year-old, right hand dominant, chef by occupation, fell on wet surface, uncontrolled hypertension, which we managed to control. AO type 1 to A2 without distal neurovascular deficit, right hand dominant. So this is not a comminuted fracture, the mild spiral in nature, but I could get, so these are, sometimes we do get these kind of excellent reductions via anterior approach, not always so. We need, the principle is length, rotation and relative bony contact. 6 months post-op, complete consolidation, clinical results, scar, patient has no complaints. Case 3, 26-year-old lady, fall at home, right hand dominant, left humerus, midshaft fracture, mild comminution, type 1 to B2 or 1 to B3. Immediate post-op, used a longer plate because some issue during the intraoperative part. In all these cases, 1 cortical screw on each side, 2 on locking on both the ends. 6 months post-op, clinical results, no complaints. This is one of the initial cases that I did, from which I have learned. So this I have purposefully put to see, to show I haven't been, I have learned from my mistakes, and God has been kind on me. Something similar to what I did today, but today was a bit lower third. I used a shorter plate then. I used a KY to hold on to the plate to get the alignment, which now I use a 3.2 drill bit through a locking sleeve. I could not manage to remove the KY. It got stuck, so I had to just cut it there. Reasonable reduction. 2 years post-op, complete healing. Range of motion. So the goal is no complaints. The goal is length, rotation, acceptable bone-to-bone contact. Thank you. That's with Professor Therachai, from where I learned the technique for the first time. Thank you.
Thank you.
Those of you who want to see the video of Therachai is beautifully there on the YouTube.
Yes, sir.
Where he has demonstrated all these things, the nerves which are nearby and everything. I think it is one of the best videos which I have ever seen.
So actually, when
on this.
When I was there, he was doing that cadaveric dissection, wherein he put a plate, drilled all the screws, and he actually has a paper which suggests which screw is more prone to cause radial nerve injury from anterior to posterior.
While you're
Sorry, I'll show you, sir. Just a minute.
so while you're live surgery, you're making a point of 2 screws only distally.
Yeah, so because in this the fracture in the live surgery was very low, so I wanted to have 2 screw gap between the fracture side and my fixation.
So otherwise you would put in 3 screws also without a problem.
Yes, sir. So this is the paper by Professor Therachai, wherein in 18 fresh cadaveric fixed with 10-hole locking compression plate by anterior approach. Average length was, and if you see the most dangerous screw that penetrated or touched the radial nerve, wherein the 6th and the 7th hole.
Please come on the mic.
So I use a LCP, so I do not contour. Sometimes if your fracture is extending more proximally and you have to slide the plate more proximally, then anteriorly you may have to lightly contour the plate.
So what is the chance of injury to the musculocutaneous nerve and the radial nerve in the distal incisions? So what do you do to avoid
So
it?
so the approach itself describes. So first thing is to once you retract the biceps medially, you have to identify the musculocutaneous nerve. Once you identify it, it's usually on the medial side. So when you split the brachialis, you split it away from the musculocutaneous nerve, and then with the brachialis, you retract it with a right angle retractor, Army Navy or a Langenbach retractor. Do not use a Homans retractor. And same thing goes for radial nerve. The lateral part of the brachialis, which is retracted laterally with the Army Navy, helps protect the radial nerve.
Hi, Dr. Dati from Mumbai. Great presentation. I
Thank
just
you.
want to ask you one thing is, what principle is this? Because this doesn't fit into any of the principle. It works, but it doesn't fit into any of the principles.
So it acts like an intramedullary splintage, sir. I mean, extramedullary splintage.
So
Internal splint, I'm sorry.
Splintage. Okay, right, okay. Because it doesn't fit into any of the fixation techniques, principles.
Where do you get the tunneling
With the
instrument?
MIPO fixation where even a transverse fracture, which he has shown them, it shows a good amount of callus. Otherwise, when we do posterior and compression, we get a primary union. So this is a secondary union he gets out of that.
Yes, sir.
Where do you get the tunneling
So
instrument?
this is a Indian instrument from Nebula, sir.
Nebula.
Yeah.
Okay, we are in a married show here.
Thank you, doctor.
Thank you.
Thank you.
Thank you so much, sir, for the wonderful presentation. Now, let's call our director, Dr. Manoja, sir, to grace the stage and put the light on this session.
Okay, this was a very good session. I actually enjoyed it quite well. Our first case was first case we made the point that why an olecranon osteotomy might be needed. So if we have a combination right in the middle so that the intra-articular piece is separate from the lateral of the medial column, I think olecranon osteotomy is indispensable. Like we heard Dr. Tanna saying that he would do a olecranon osteotomy to examine the whole of the whole of the trochlea, even in otherwise. But we had a presentation which showed that a para-olecranon approach also might be good enough for that. Our second case was an infected non-union. We learned a lot. One of the messages in there was that if you want to apply a cast and a conservative treatment for such a fracture, you cannot have a hanging cast for a transverse fracture. You have to have a U cast so that it is supported in the shoulder. Otherwise, the weight of the limb makes this fracture distracted. And of course, after an infection, it is always a nightmare. We had also a show of hands to show that putting in a tricortical, unvascularized graft in an infected situation would not be a good idea. Our third case was a complex fracture with a humeral shaft hypertrophic non-union and an intra-articular fracture associated with it. We learned that nailing in this situation may require a superadded plating also if the fracture is present in an area where the medullary canal is much more wider than it is an isthmus. And then last we already discussed that the point was made about para-olecranon approach, and the last we saw the MIPO. We had a beautiful surgical demonstration of the technique also. Thank you very much for listening. We thank all the speakers also for contributing and sharing their experiences with us. Thank you very much.
Thank you so much, sir.
Thank you.
So we have come to an end for the second session, distal humerus fracture. Thank you again, Manoja sir and Chandramouli sir, for gracing the stage. Now we'll go on for the third session of the day. Let's begin. The topic would be distal radius fracture. For the same, we would like to call on the stage Dr. Deepak Raina sir and Dr. Sameer Mehta sir. Panelists for the same would be Dr. Samat Mittal sir and Dr. Asim Negi sir. Requesting Dr. Sameer Mehta sir to come on to the stage.
रहा तो नहीं? Okay, good evening everybody, and it's great to be here. Okay, I'll not be taking much time, but distal radius fractures, we know the results of various trials held in various places. Whatever you do, they tend to do pretty well after a year. Okay, one of my most difficult cases. Would anybody operate in this patient? Raise of hands. I know none of my colleagues would want to operate, but being the most important person in my life and being a very a worker who has skills and who wants to work with the hands, gave her a plaster. Not comfortable. In a week's time, she got a CT scan done at her hospital. And finally, we were forced to put a plate. So in order to put a plate, we don't want to actually cause any damages. It has to be precise. Certain fractures are self-evident. You need to get a CT scan done to see the intra-articular configuration and fix them. We'll get to know more in detail about such fractures by the speakers coming, so I will not go in details, but yes, we need to fix them. We cannot fix the ulnar styloid here, and I believe Samarth is going to tell us about that. Some other fractures. So in our setup, we will operate most of the fractures. I'm not sure about everybody else, but in our setup, we will fix most of the fractures, at least pin them and put a plaster on them, because the population where we work, it's mostly elderly population. They are independent because their kids are abroad. They are forced to be independent and they are forced to get back to work as soon as possible. So even in elderly, we cannot afford a long-term plaster. Okay, I think sometimes we have to fix the ulnar styloid also, depending upon the fixation. I will end my talk here. I'll get the ball rolling. I'll ask Samarth to come and talk about a few cases. And let the session be open. We can interrupt all speakers whenever you want, whenever you're comfortable. Please don't hesitate in interrupting speakers, because this needs to be an interactive discussion. Samarth, please.
Thank you, sir. So good evening, everyone. I'll be just talking about a simple distal radius case. So you see how perspective changes. I don't work very far away from where Dr. Deepak Raina works. I think we are hardly a few kilometers away, but in his practice, most of the distal radius fractures would be operated, while in my practice, most of these fractures would only be conserved. So most of the extra-articular distal radius fractures, most fractures that become reduced after reduction and manipulation and put in a plaster would go conserved for me. But this is a case of a 39-year-old male who has this comminuted distal radius fracture after a high velocity trauma. He fell from his bike, and he is a right-handed gentleman. He's right hand dominant. This is the right wrist that he's fractured. He was a PhD scholar 3 years back in our institute, and now he has joined us at a regular post as a scientist in our institute itself. And this is the post-reduction films. Most of these patients get a reduction, and then we comment whether they need a surgery or not. So, question from the panel, sir: conserve or operate? I know, Deepak sir, you have already said that you would operate upon most of these. Sameer sir.
Samarth, this is a young man with, like you say, dominant hand. He has his whole life ahead. Intra-articular,
I would operate.
Samarth, my question to you is,
Sir.
if he was not a PhD scholar of your institute, would you still have treated him the same way?
No, sir, this is a intra-articular fracture, so Samir sir has, so the message that I wanted to give here is extra-articular fractures probably we would not operate where the length is maintained, alignment is maintained and the joint is congruent. But here the joint is definitely not congruent and there are a lot of signs of instability. Even the distal radioulnar joint doesn't look reduced right now. So these, irrespective of what these patients are, unless this is a 90, 100-year-old lady who doesn't need much of a function, most of them will get
all extra-articular fracture you will conserve?
Sir, most of the extra-articular fractures I would conserve, but the treatment is dependent on the patient and a lot of other factors as well. But yes, I would most of the time conserve most extra-articular distal radius fractures because they happen in the elderly with a low velocity trauma where they would have low functional demands. But
If there is a crushing at the posterior part of it, on the dorsal part of it, crushing, which you will get the reduction intraoperatively whenever you're trying to do it, but he is going to go back into that same position. And that's the reason when there is a younger man without crushing, yes, I agree entirely. But in a man, even if he is younger, but there is a dorsal crushing which is there with the posterior displacement. I think they are the fractures which will probably, they will redisplace in the plaster itself.
So, absolutely agree with you, sir. But on day one, I would still, if I have a good reduction, I would conserve these fractures. At the end of 1 week, I would get a repeat X-ray done and see what happens. Because in 1 week, I'm not going to lose anything at all. In fact, it is going to help me with the soft tissue healing with my surgery. If it displaces, yes, I'm open to a surgery. I don't mind operating upon a distal radius fractures, but I do mind operating upon a distal radius fracture that can be treated without a surgery and having the same result. But at the end of 1 week, yes, sir, if they displace, yes, I will operate. Even at the end of 2 weeks, I would operate. So I would get X-ray at 1 week, 2 weeks, and then 4 weeks.
Yeah, I agree, that part. That's right, that's exactly what he is saying. He will reduce the fracture. After a good reduction, he will plaster it, and in the plaster, he'll take an X-ray after a week and a 2 week. Anytime if it displaces, he'll go ahead and operate.
The problem is the treatment in Jaslok and Nair Hospital used to be slightly different. So that is the issue.
So I'm open to a surgery, and this is certainly a patient that I've operated. This requires a surgery in my view. So like all the panel has discussed, this needs surgery. Sir, how to go ahead? What to do next?
One point Dr. Rana just made that comment on is whether if he wasn't a PhD scholar. Now, it's not about being a PhD scholar or being a daily wage laborer. The question is, many times when you are, when you're thinking which way to go, operative with this, sometimes a patient pressure to some extent does play a role. A demanding patient who's well-read, who's already consulted 3 patients, can make a little bit difference here and there, I believe. After all, we are all humans, after all.
Summer, preferred trial was about patients which were outright black and white. Operate and in the gray zone it included and then randomized. This is not in the gray zone. This is in black and white zone. So
Yes.
I think it's difficult to find out any age unless you are saying that ejection fraction is 20% and something like that.
Yeah. So
that's okay.
I agree with you, sir. Even if this was not a PhD scholar, I would operate, but that is certainly something that would need me to give better results. He works at my institute on a permanent post now. So
Let's proceed, Samarth. Let's
what to do next, sir? What would you?
CT scan would be.
CT scan.
Yeah.
So these are the CT images. So certainly look like a bad fracture. You see dorsal comminution that Tanna sir was talking about. There is volar comminution. The fracture line on the volar ulnar lunate fragment, which we know is the most crucial keystone fragment of the distal radius, seems to be very far distal and displaced. We see a distal radius intra-articular joint fracture which is slightly depressed, and we see displacements on the volar part here and the dorsal part with dorsal comminution here. So, and I have a CT scan of and in all the 3 views as well, just to give a better clarity of these. So Next question, sir, what to do, which approach? We know that we need to operate. Now this is displaced. It has articular comminution, it has dorsal comminution, and the articular fragment is depressed. What to do, sir? Anything?
Anybody from
Or
the audience
anyone?
would like to take a call?
Two-way we can treat this. One way is either use Kapanji technique and external fixator. If you want to do closed method.
Yes.
And if you want to do open reduction internal fixation, dual approach, dorsal as well as volar. Volar side you need periarticular plate.
Let's take a call. Who all would like to go for external fixator only? If you can raise your hands, external fixator once. Not many. So everybody would like to do a ORIF, open reduction internal fixation with plating. Most of you?
Single incision? Single incision?
Yes, single incision. So if we see here the dorsal piece, it is not comminuted and it very well reduces with a volar directed force. The radial styloid is a big piece. It does not need much. The most important, as he said, it is the volar lunate fragment. We have to use a plate or plates to hold everything in place. So for this, a periarticular plate sometimes become difficult because we cannot place it more and more distally. So there is a limit for that, but there are multiple approaches. You can use K-wire, pin plates. There are multiple options to use this, but that piece should be reduced well. And the die punch, I think it reduces with traction in this case.
How do you assess through the volar approach? How do you assess the intraarticular reduction through volar approach?
So in this case, I can see it is not much depressed, it is over the rim. So we can very well assess this in case of with C-arm. But yes, if it is too much depressed, then I would go for a dorsal approach, open the book, reduce it, and then close the book.
So there is dorsal comminution here. If it's very clearly visible here in the CT.
Yes, but that just reduces with traction.
I don't know what is the opinion of the panelist, but I feel slightly against that. Any depression in the joint will never come with traction. Whenever there is joint depression, whether it is tibia, whether it is femur, or it is distal radius, if it is depressed, depressions don't come back with traction. Joint depressions don't come back with traction, only the metaphyseal and articular surfaces come back, depressions don't come back. That is what I strongly feel, but I would need an opinion from the panel.
You could, if you are doing only a volar approach, you can push it through the fracture.
Yes.
Just
yes,
like we do the
yes.
tibial condyle, we can, but again, it's very difficult to assess it. So in order, ideally we should visualize intraarticular fractures, and we should have I personally feel that we should have a very low threshold in going dorsally and visualizing them. Even if you don't fix them dorsally, but you should have a very, very low threshold. It's a beautiful approach, doesn't harm much, and you should go dorsally and visualize if you have any doubts in the intraarticular anatomy.
Samar,
sir.
In my presentation, I will show a case where I use Orbe's maneuver. 3 weeks, 4 weeks down the line, you can use extended FCR approach and hold the proximal fragment with a Warburgi and pronate that, so that you, as Dr. Deepak rightly said, that you go from within the fracture, clear out the hematoma, and then you are seeing from inside and radiologically. And my threshold for putting a dorsal plate is very low. They don't cause much problem if your dissection is good.
So 2 points there to note. One, I'm glad that you mentioned about the Kapanji technique there, and 2, the George Orbe approach, which is the volar approach through which you hold on to the proximal fragment, rotate it out, look at the dorsal fragments, bring them back in place, get the dorsal reduction right, and then put a volar plate. So those are the 2. Yeah. So this CT has been shown. So I went in, and like I said,
Do you have a traction view on the table?
Yes, sir. So this is the traction view, and I'm trying to do a Kapanji maneuver. I'm trying to put this wire in and get that die punch fragment right in, back in. It works in some cases, but it did not work here at all. So what I do is I just put a K wire and push it in just below the fragment and try to push it out like this. Did not work too well here. Nothing was coming in place. So like Deepak sir said, I went in dorsal, put the dorsal fragments back into its place, and most of the time all we need to do for the thin dorsal fragments distally is just buttress them. We do not normally, that's what I feel, I do not normally need screws distally in the dorsal fragment at all, because these are very weak fragments. All they need is buttressing and the correct length. So even though the AP view doesn't look too good here, but the lateral is doing its job. So with both those plates, I don't want a plate on the Lister's tubercle. So it's on either side of the Lister's tubercle, 2 plates, and pushing everything down. Still that radial styloid fragment and the lunate fragment is out. So I've gone in from the volar approach then. So in all these patients, we should be open to doing fixators, K-wires, lifting up the dipunch fragment, going dorsal or volar, and or both at the same time. And then I've gone in volar. And this is called the sandwich approach. When you go in, get everything reduced and just sandwich the fragments in between so that you have a buttress from the volar side and the dorsal side. And I've gone in and put in a clamp to get the reduction right. I heard someone saying there's an intra-articular screw. Very nice point. This is not the view to check for an intra-articular screw. You lift the wrist up 15 to 20 degrees and then see a shoot-through view, because most of the radial styloid fragments, you see here, whenever there is a screw in the radial styloid fragment going here, they will always look intra-articular in this view. So always take a lateral with 15 degrees wrist up. Same about a AP view as well. And this is the immediate intraoperative X-ray. These are the screws that make it look intra-articular in the lateral view, which someone has commented looking at this view. But I'm sure there was no screw inside. This is the immediate post-operative X-ray of the patient. Any comments, sir?
Pretty well done, but it's more of a taco than a sandwich with 3 sides being pressed.
And this is the 3-year follow-up of the same patient. That's the opposite side X-ray, just for comparison at the end of 3 years. This is yesterday's X-ray, both of them. And that's the incisions on the volar and dorsal side. That's the flexion, that's the extension, that's the pronation, and that's the supination of this patient. So the only thing I wanted to bring out from my case was that dual approach to distal radius is rarely required, but if it is required, we should all be open to this technique. If needed, we should be prepared for a sandwich technique. So whenever we see these very distal fractures, it is known that very distal lip fractures, we always tend to put plates beyond the watershed line and try to control these fragments. But it is known that they can be better treated with a dorsal approach as well. But it is surgeon dependent. But reduction of articular fragments is the key. Do not depend upon traction for bringing in die punch fragments, or I think depression in any joint. Some part of the joint, if it is depressed, it will, I don't think it comes through ligamentautaxis at all, because articular fragments don't, middle of the joint, they don't have any attachment of any ligaments on them. So ligamentautaxis will not work in die punch fragments. That is what I feel. And getting good stability is very good for early rehab and good outcomes. So don't be afraid to put 3 plates. I have put 3 plates here. I have put 4 plates. I have put 5 plates in distal radius fractures. But getting a good stability is the key, and getting a good articular reduction is the key. Whether it is done by 1 plate, 2 plate, 3 plates, that does not matter at all.
Samad, one point, could you just quickly go to the X-ray part before the CT, before you show the CT?
The
pre-op, yes. Why I want, it's just beautifully done, of course, both approaches, well shown, well done. I was wondering, do we see depression? Yes, we do. So we can see even depression in an X-ray, even without a CT. So if not many places have quickly, easily available CT, so we can still take a decision on X-rays. Any comment on that, Samarth?
Sir, I'm a spoiled boy. So for all my articular injuries, I think I get a CT scan done, and that is how I think things should be. For most of the articular fractures, unless there is some really real indication that a CT cannot be done, pregnant females, or there is some other reason for not giving radiation, I think it gives me a peace of mind, helps me plan more effectively. I think I require a CT scan for most of my difficult intra-articular fractures, and that is the message I want you all to take. Yes, if you work in a setup that doesn't have CT scans and you are God, then you don't require a CT scan.
Samarth, did you pack the void with chronos or anything, allograft or anything?
No, sir. Not in this case. I've put subchondral screws. So yes, grafting is an option, especially when with the approach that Dr. Deepak Khanna was talking about. These fractures can also be treated only by a volar approach. But in that case, you go through the fracture, put in graft, and try to keep it up, because the subchondral screws don't go so well. So in those cases, graft can be put, but I have not used any graft in this case.
Could you give us a technical tip on how to get this radius close to the ulna, the distal part? Because we end up fixing them well, but there's a gap distally.
So that's the reduction clamp there. I've got the ulnar fragment, ulnar linear fragment close to the ulnar head, and then I've brought everything close to the ulna with that clamp in the center. This clamp is getting everything towards the ulna. But the keystone is the ulnar lunate fragment, there is no doubt about it. Volar.
Another important point is that it is extremely important to align this corner, to tighten that DOB.
Yes, sir.
Otherwise, you are not having a good painless pronosupination. So this Shenton's line, if we can call it, has to be absolutely normalized. There cannot be a lateral translation of this or this piece.
I agree with you, sir, absolutely agree. I have a lot of more cases, but I think I have got my take-home message very loud and clear. I don't want to take up more time. Yes, if you have a question.
So can you please go to the post-op follow-up X-ray, please?
Yeah.
So in this also the lunate fragment is depressed. Would you not want to add a rough K-wire or a subchondral K-wire in all this so much of hardware and just keep it there? Because it is still depressed, and as you said, you did not use any bone graft or Kronos, as sir said. Isn't it that we want to do it that way, or just keep a wire? Also, once you have exposed it volarly, you will reduce it and just keep a wire like that and do your preliminary fixation, maybe the dorsal, and we can also put a dorsal wire to the small fragment. So this dorsal plating.
I definitely agree with the second part of the comment. If in doubt, if you think that it is depressed, keeping a K-wire, keeping in bone graft is a good key. I don't know if I still can't see the depression, but if there is, then I am
So the
mistaken.
distal row third screw from the radial styloid is in the fracture. Is it? Sir, I don't know if it is.
I don't know, I'm probably biased.
Oh, no, I understand this. Thank you, sir.
But your point is absolutely right. If there is a doubt, putting in bone graft, putting in a subchondral K-wire, putting in subchondral screws is the right thing to do. So if there is a message, then your message is right.
I heard Smarth you saying you put in 4 plate, 5 plate. 3 is good. I could see where you could put. Where would be your 4th and 5th plate, just to bring out the point?
Sir, 4th plate is usually on the radial styloid. If the radial styloid is comminuted and it is impossible to get it reduced, instead of using 3 or 4 K wires, I want to get good stability and get it moving. And sometimes the 5th plate I put on right on the ulnar lunate fragment if it is a very small fragment. So I've done a few cases, 3 or 4 cases with 5 plates as well. But the message is not using a lot of implant. Message is to get it reduced and to keep it stable till you get good union. And the worst thing to do is to operate and keep your patients on a long plaster.
Yeah.
It is proven by studies that the articular cartilage behaves worst if you operate, do a open reduction, and then you put them in a plaster.
Right.
So the key is try not to keep your patients in a plaster for a long period of time if you are operating upon them.
Thank you, thank you.
Extension hook is extension hook.
Yeah, I sometimes use, if I don't have fancy plates, I use a wire, 2 wires into the distal fragment, just bend them and put a simple plate over the top of those when the fragment is too far distal.
Sir, how about the radial styloid plate irritation? How frequently you notice, and how much it requires implant removal as early as possible?
To make a point, sir, in my practice, 80% of my distal radius fractures are going to get conserved because most of them are Colles fractures. Out of those 20% that are going to get operated, most of them are going to get only a single volar plate. Out of the left 3%, most of them are only going to get 2 dorsal plates. Left 1% is going to get 3 plates, and the last 0.5% is going to get a radius plate. So I think, given my 12-13 years of experience in orthopedics, I am too underpowered right now to give you a comment on how these radial plates behave. But out of all the cases that I've used a radial plate, I've never had a problem. But I think it is too early for me to say operating upon 10-15 cases with the radial styloid plate does not mean that I'm a master in it and they all do well. Probably the next 10 will cause pain. So I don't know. Maybe someone more experienced here in the panel or Tanna sir can comment on that.
Trick is to use plate which are buttressing but are not rigid. So you can't use poor quality stainless steel plate. Even the stainless steel is not the issue. Titanium or stainless steel is not the issue. The plate has to be buttressing, supporting, but not very rigid. So it just goes and hugs there, and you have to spend some time making it flush on the bone.
Even in this, the dorsal plates don't have any distal screws.
Yeah,
They
I
only
have
are
put enough
buttressing.
and have not removed many, hardly any probably. And last so many years, one patient had a FPL rupture, but that was the plate put long back when there was less information. That patient also was told to get it removed and did not turn up for removal. So the tendon broke at around 3 or 4 years, but she wasn't complaining because she was told in very early post-op period that 6 months down the line this plate has to come out.
In this patient, I keep worrying about dorsal plates with the tendons. But after 3 years, this patient has, the only X-ray I have is at yesterday at 3 years. And the only other X-ray was immediate post-operative because this patient never had any problem. He never wanted any X-ray done. I had to beg him yesterday for this X-ray. One of my residents got it done. कि भाई department के HOD को बोल दूंगा, तो please आके एक X-ray करा ले. I'm worried how it is going, just to get this X-ray here. But the patient is absolutely symptom-free.
Thanks, Dr. Samant. That's a point well given.
Thank you.
Use discretion. You said in a busy hospital like yours, All Indian Institute of Medical Sciences, and 80% you said I treat conservatively. It's a big statement. So use discretion. Needed, go ahead and put as many plates.
Now you feel that because he is busy, that's the reason he is really treating conservatively?
Sir,
I think scientifically he feels that they need conservative treatment.
Yes, sir.
Am I right, doctor?
Yes, sir. Yes, sir.
Thank you very much, Samarth.
Thanks.
So, Dr. Negi, sir, this is all yours.
Here is a 77-year-old active male, injury on his dominant hand, fall at home, and he is father of an extremely busy, very well-trained orthopedic surgeon who was working for almost 15 years in UK. So this is the X-ray, and can we have a vote quickly? How many people will want it? How many people want to operate on this? He was given a plaster, and 3 weeks down the line, here he is. Now almost everybody will like to operate. So we got a CT scan done. As you can see there, there is central depression, there is significant radial shortening, there is severe metaphyseal comminution, and there is a volar fragment. So this is not an uncommon scenario. Fracture was actually unstable. So, sorry. So क्या nonsense है? Yeah. We got X-ray of the opposite wrist, flipped it open. We know the normal parameters, and that is what we want to do. Here is that extended FCR approach, Orbe's maneuver. You can see there, this Warburgi is holding the proximal fragment. We have exposed the fracture, we have removed, stripped the dorsal periosteum from proximal fragment, and now we pronated it and cleared out all the organized hematoma and the fibrous tissue from within the fracture. The assistant is giving traction. One hand holding the Warburgi here, left hand, and the other hand, I just push this distal fragment volarward. Here comes a very blunt periosteum which levers out the distal fragment. So all the forces are working simultaneously. He is pretty old, bones are osteoporotic, so you can't really use any force. Everything has to work in tandem, and then you reduce that fracture by translating the distal fragment volarward. Is coming, and this is the reduction. We pass these K wires, tentative K wires, for holding this reduction from proximal radial to distal ulnar. Check the reduction. Here you can see that this distal fragment is pretty small, is hardly 12 millimeters. So this is a fracture where only a periarticular plate will fit in, and rim plate is one of the better things to fix this type of fracture. So here comes the rim plate, and then styloid fragment. I felt that it's not really nicely supported, even though rim plate allowed me a 2-row fixation. So I buttress it with a radial styloid process plate, and here here is the patient at 3 months. This is the only X-ray which I could get. Happy patient. And here is another patient, 53-year-old male, 6 weeks old fracture. He had this type of function. Very active male. The options are leave alone or investigate. So we chose to investigate him. You can see that the whole corpus, as Dr. Samarth was pointing out, if you leave this volar ulnar fragment unattended, without buttressing, then the whole corpus is going to subluxate volarward with this. It goes with that volar ulnar fragment. And your pronosupination goes down the line then. This is the CT scan. You can see that this is the volar ulnar fragment here. As you go laterally, it is thinning out, becoming smaller and smaller. The corpus has significantly gone volarward proximally with VLF here. And these are some more cuts there. There is a styloid fragment also, but it's not in a bad position. And this is, yeah. On a console, you can measure the length of this volar lunate fragment. It's hardly 1 centimeter. So it's pretty small, and the corpus has gone. So I think Dr. Deepak's presentation had a slide. This plate going so far, you simply cannot do this. This is criminal. This is very prone for flexor tendon rupture. This plate cannot cross the watershed line. It's not meant to be used like this. So you will have a FDP rupture. The nice thing to do is to use a rim plate, easy to use, but if you don't have access to rim plate, there are other options. Few words about this rim plate. This plate was developed specifically to treat very distal fractures which require fixation distal to watershed line. Patients with volar plate prominence should be screened for symptoms of tendon irritation, and that plate should come out if patient has got symptoms. You can use an ultrasound to do that. This is another paper. The short radiolunate ligament is attached on this volar lunate fragment. And if it is small, this happens in about 1/4 of the patients, and if it's small and not buttressed properly, then it may result in a volar carpus subluxation. Another paper which talked about the size of the fragment. If this fragment, volar lunate fragment, is less than 15 millimeter and is subsided more than 5 millimeter, then there is significant risk that you will end up with a carpus subluxed volar world. So be careful about fixing this. These are the various modalities you can use to fix it. Rim plate, of course, we saw. You can use tension bend wires like this. You can use a headless compression screw. You can use a extension hook, which Dr. Samarth was talking about. This is your ordinary volar plate, and you can join an extension hook, and these prongs can go and buttress that fragment. They pierce that fragment and buttress it. This particular patient we chose to operate by extended volar approach. Incision has to go slightly more distally up to the scaphoid tibial curve. Expose the volar capsule, but don't damage it to preserve the vascularity of the distal fragment. Proximal part of the volar carpal ligament you can release, but don't release it completely most of the time unless there are median nerve issues. This is the picture which tells you about the volar rim. In most patients, you will be able to palpate this rim, and usually I put a 24 number needle here and check it under image intensifier, which tells me the exact location of the joint and the orientation also. This is the transitional fibrous zone, and this is your watershed line, which is about 5 to 6 mm proximal to volar rim, and no plate which normally is meant for volar fixation, except rim plates and other periarticular plates, should cross this volar at this transition watershed line. And then you make a L cut in the pronator quadratus here and peel it off the whole thing and expose the volar surface of distal as well as the proximal fragment. Then I almost by default go on to release if the fracture is more than 3 weeks, 4 weeks old, I got no hesitation in releasing the brachioradialis completely. Some people do Z-plasty, but I like to strip it. Don't do a jet-plasty most of the time. Rarely I resort to that. When you are doing this, you have to work in this V angle here and be careful of the first compartment tendons. EPB and abductor pollicis longus are just seen there. So have patience meticulously with a sharp dissection. Just go on peeling it off from the styloid thing. The brachioradialis will go away. Tendons are seen, but they are not touched. So you can open this septum. Tendons, they stay away. Keep them under vision. Stay away, basically. Now my fracture has been completely exposed. You can see that both the fragments with sharp dissection, and then the same maneuvers, the periosteum, blunt periosteum, pushing it distally, somebody giving a traction, trying to restore the length, holding the proximal fragment, and this is my post-reduction X-ray. After that, what everybody is taught that this plate will buttress and it will hold the reduction. But till the time plate is fixed, you are really struggling and plate will never reduce your fracture. You have to put the plate on a reduced fracture. So what we did, we chose 1.5 millimeter K wires. Our needle in the joint tells us the exact location and the direction, orientation of the joint. So these wires, they go in the meat of that fragment from volar side, very close to the joint line, and hold my reduction so that I have got an intact radius to plate. This is the tip of the guide wire. The wires have been drawn out from the dorsal surface. They are cut short so that when I keep them on a towel, they don't bend or disturb me. This is the cut wire. This is the volar tip of the wire, and then comes my rim plate there. I checked it on the X-ray. It's 3 millimeter more proximal. They have given an oblong hole. So screw is always placed such that I can go up or down few millimeters. And this is the screw in the oblong hole. And you can see it there, that this screw was here, and I pushed the plate down, and it comes in the proximal part of the oblong hole. So now the plate will sit where it's supposed to sit perfectly. This is good reduction. Buttress plate is there. You can see that this whole volar carpal subluxation has been nicely corrected. It's all aligned, and the wires, they go out. This allows double row fixation. And at the end of every surgery, you are supposed to take 4 views. 2 views Dr. Samar talked about. You have to take a 10-degree, lift the, this PA view, lift the hand 10 degree off the table, 20 degree for the lateral view, and this is your dorsal tangential view. You have to keep the elbow like this, rotate it 15 degree. You have to juggle a bit, 15 degree, sometimes 20 degree, and the C-arm is shooting from here. So this is described in the book. Every distal radius fixation, you are supposed to take this view, and this will tell you that none of the screws is piercing the dorsal cortex here. All screws should be within this line. If any screw is penetrating, then it's likely to cause EPL rupture. And you are supposed to take both oblique views. The oblique views, they help to detect dorsal screw penetration in the second and fourth compartment, while dorsal tangential view, which we saw just now, will tell you about the penetration in the third compartment, EPL. And a word about screw length also here. None of the screws should be more than 75%. As Dr. Samar showed that if you have to really bite this cortex, you feel that it's not stable, go down dorsally and put a buttress plate on the dorsal cortex. Don't try to pass a longer screw and try to fix this dorsal cortex by having a longer screw. You will definitely end up with extensor tendon rupture. So if this fragment needs support, put a dorsal buttress plate there. Don't put a longer screw. And this is the picture finally. Closure, a word about closure of pronator, whether you should suture the pronator quadratus or not. So literature is divided on both the sides, but conclusion is it's not really necessary. I still do it out of habit. Sometimes it succeeds, sometimes the closure is not that good. There are papers which suggest that if you suture the pronoted quarters over the plate, it's more, it does more harm than good. So you can have your own philosophy. And here is my patient, and this is his long-term follow-up, 6 months, I think. And no, that's a 2-year follow-up, I think. Yeah. So this was about the volar rim fragment. Any questions? I feel that distal radius fractures, those which are intra-articular and have gone really haywire, age cannot be the criteria for not treating them properly. Medical comorbidities may be, that patient is not really very fit for any 2-hour surgery, but and now lot of hardware which wasn't available 10 years back is available, which is very customer friendly, patient friendly and surgeon friendly. So, and dorsal plating is, I think it's just a mental block. People have not seen it, so they don't do it. You see it once, you will be able to do it. There is no issue. Just learn to raise that subperiosteal flap, retinacular flap, which you can put back over the plate and suture it dorsally. And keep EPL tendon free. Don't try to put it back in its sheath. Keep it subcutaneous, and I don't think there should be any problems. Thank you very much.
Thank you, sir. Excellent presentation.
Wonderful presentation. So any question for any of the presenters? Anything? Samarth, do you have a point to make? Anything? Now you're on the other side of the table.
Proximal fragment. So it is very, very important to be very careful, like sir said, with a blunt periosteum, and try to pull them out more and hook them only in the internal part. Sometimes if I'm afraid, I just use a artery forceps for that.
I won't agree. Any narrow instrument is bad. A broader instrument will have less force per unit area. Plus, you need 2 people at least who understands what you are doing. So, 4 hands are working in tandem. Somebody pulling it proximally, somebody giving traction, your hand pushing it from dorsal side, and periosteum working. So
Yes.
these 4 things have to be absolute synchronized. No hasty maneuver or pressure.
Yes, sir.
Plus, my threshold for putting chronos there or allograft, whatever is available, is very low. If I raised a fragment, I don't lose anything by putting it. You don't need autogenous bone graft in that area.
So one fear is always that you're putting too many implants in a very small compartment, in a distal part, but then you showed and Dr. Negia showed that that's none of the issues. And age definitely is not an issue. So this is one thing which an average orthopedic surgeon always has in mind, not to indulge in aging patients. So I think with this, if there's no other question, I think we can call it a day for this session. So this session is closed for the organizers.
Age is a consideration when I am doing a redo surgery for a malunion. If patient is not really symptomatic, in a younger patient, I may still be less conservative because he has to go on for another 40 years, and if a slightly less active beyond 60 wala is not having problems, then I will not be offering him surgery.
Tanna sir, could
Ali,
you have
that is very unfair, Negi. You 60 wala, you don't offer a treatment. It's very, very unfair to him. I'm talking about redo only. And any observations on a redo surgery, injury to the radial artery?
I'm generous with my incision.
It has nothing to do with the incision.
No, I
is that right?
start in the normal area.
I'm talking about the redo where everything is fibrous. You have put in a plate which is badly situated. You have to remove those plates and put back the whole thing. I have injured it twice. And then I think you'll have to be aware of it, and you can really stitch it back, and then the whole thing comes back to normal.
It's very likely. Even trying to suture the pronator quadratus, you can take suture through the artery. सारा सर्जरी हो गया, सब अभी बड़ा खुश एकदम, and you just try to repair that pronator quadratus, and it has to go somewhere on that lateral side. And
In a virgin case, it doesn't happen, but in a redo, it is very susceptible. And even if you really tie it up, nothing happens.
Yeah, because there is a nice good. After removing a plate, it happened with me once, trying to close the soft tissue over that.
पूछा तो ना बोला तू.
No. My needle, I did not damage it. My needle went through that. I waited for 6 minutes. It was 30 something. So needle was very thin. I waited for 5-6 minutes. The bleeding stopped. But I punctured the artery. It wasn't a cut. By suturing it, went through the wall.
This has been a truly lively session. So to conclude this session, we would like to ask Dr. Deepak Raina sir for some closing remarks.
Okay, we had two wonderful cases, both of them highlighting the need to do intra-articular reduction, particularly the ulnar aspect of the radius. We have to be very careful about that because that is the articulation which will cause a loss of pronation and supination if we don't fix it well. We should not hesitate to go dorsally if we feel there is any intra-articular combination which we are not being able to deal with. And sir showed wonderful techniques of doing it through volar approach and getting the depressed intra-articular fragment up. And so we two wonderful cases, great presentations. Thank you both.
Thank you, Dr. Raina sir, and Samir Mehta sir, and Asim Negi sir for gracing this session. Now we have almost reached the end of today's list of events. So before calling it a day, let us announce one of our game-changing product lines that is soon going to change the operations in the orthopedic industry. Auric Bionic Gold Plating System. It is coming soon, and here is a teaser for you.
Good evening. So these products, Auric Bionic Gold Surface. So what are the current challenges in the trauma? Number of plates and screws need to carry in the surgery. Prediction of size cannot be judged before surgery from the X-ray. Product need to undergo autoclave before surgery. Need to communicate to the distributor or manufacturer to provide the stock required for the surgery. And time consumed to provide the implants for the surgery from distributor to manufacturer. What is the solution? Anytime surgery, ATS, Auric Trauma System. Advantages of ATS system. ATS is a unique concept for sorting and retrieving required implants in the OT. ATS has systematically organized slots for the top 62 cores of the implant. The screws are stored in a sequential pattern in the special design drawers. Very clearly labeled information helps retrieval very easily. This concept allows trauma surgeons assess the required implants without pre-ordering them in case of emergency. The availability of implants make the surgeon's task very easy. Mobile-based application. This cards comes along with a mobile-based application called MAS, M-A-S. Informs the user the exact stock situations and inform Merrill supply chain to replace the used stocks. Seamless operations would make the transaction simple and quick. There are implants stored in this trolley can be take care of 180 surgeries. So you have the implants for 180 surgeries at a time in one cart. And Merrill also will come up with pre-planning operative software because these are the sterile parts and it needs specific size suggestions or guess of any size during the surgery. So why does one want trauma implant to be a gold standard? Advantages of the coating. It's a TINBN, titanium niobium nitride coating. It's a special process, outstanding biocompatibility, allergic preventive, long-term chemical stability, higher wettability, reduction of ion release, and reliable high-quality imported titanium raw materials. Key features of ATS. Freedom. What we talk about freedom, you might have seen some logos on the outside of the auditorium. Freedom from surgery timeline, anytime surgery, freedom from any allergic reaction for patient, freedom for any supply chain issues, mass and intraoperative inventory accuracy software, freedom from infection worries. It's a sterile packaging. So we have this package and the product will comes in an aluminum pouch which you can open like this. The plate will be in your hand. It's a coated plate. So how the software will work, the inventory software will work, I will show that demo also. So when we enter in the application, it will show a trolley name which was assigned to particular hospital. Say in this case, we have added a Ashirvad Hospital. And if you go here, you can have a schematic diagram of this card from number 1 to 46, D1, D2, D4, D3. And when you need to do a simple click on the inward items, like when the stock will come for the replacement, you have this screen. There is a one barcode on the product box. So you just need to click on the barcode. All the informations will get automatically in the software. You need to save, and then it asks in which number you need to put that particular box. I saved it in section 4, QR code 4, and if you want to locate it, sorry, the upper part is not showing. So when you search on the product, it will show only that products which are available in the cart. So in this case, it's D11, and if I click on the locate, you will get a blinking mark where it is, and if you click on the D1, again you have a blinking mark on the one number. So it's easily identify. Anyone can easily identify where is the product inside the cart. So same way you can do a inward, you can do a outward, just on a barcode click. So after this, we are coming with the pre-operative planning software, which I will show. I would like to show a demo for 5 minutes. Sorry, I don't have any idea about it. You need to contact your RSM.
Okay, thank you. So I'm Dr. Vikas. He's Amit. We are founders of AlgoSurg. I'm not a surgery doctor. I'm a PhD from IIT Bombay. So we are making this software with Merrill. It's a planning software. Can you, just a minute, we will. Where is Merrill? Yeah, no problem. Done. It's there. Yes, yes, we will give you. Okay. Okay, good. So this is the software. It is going to be a cloud software, and there will be a mobile version. So you'll be able to use it in a web browser on your laptop or in a mobile, in cloud, anywhere, anytime, right? So you will have a surgeon's account. So I have a dummy account here. This is a demo. You will sign in, go to the software, and there will be a lot of surgical cases. So we have already created some cases. I'm going to show you one new case addition. Internet there. Okay, looks like some internet. Sorry. So the Wi-Fi. Yeah, yeah, it's there. It's there. Hotspot में? Yeah. Okay, so there is some network issue, but I have a video to show, so don't worry. I will show you a video of how the software works, and you will get an idea how it works. Yeah, yes, yes. Yeah, yeah. So this is how you will have number of cases. You will add a case, you will upload 2 X-ray images. Now, so the X-ray images are very normal, the way you take, but there will be a 25 mm ball marker, the radiological marker you will use while taking the X-ray. And then, yeah, there will be instructions. The markers will be detected automatically. You will have to place just one annotation to show the direction of the image. This helps us to calibrate the 2 images so that you can manipulate the bone plate in 3D. We'll show you in the next step. So after that, you will draw a bone segment, the distal bone segment, in both AP and ML image. A very quick step. Now that's ML image. Once you draw the segment, you can manipulate it to simulate the correction. So some transformation, rotation, translation will be there. And this will be there for every anatomy. What we are showing you is just tibia. Now this is corrected by me, so don't judge me for my planning abilities, but you might do better. And then all you have to do is just select a plate. For now in this demo we have few plates, but all the plates will be there, and most things will be automatic. We'll use AI tools to make it automatic. And you'll be able to rotate the plate in 3D. If you make manipulations in one image, the other image also, the plate will position itself. This will give a good idea of what plate and what size of plate you will need during the surgery. So there will be no surprises during the surgery. You'll also get an idea of what screw lengths you want. So you'll just click there, and it will give you a screw length which you can change. All you need to do is just roughly tell us which shortest and which longest screw you need during the surgery. And in the report, it will generate a report. It will show you not only the plate which will be required and the range of screw lengths and the corrected AP and lateral situations. So that's it. So this is just a demo software, and we'll be around even tomorrow. If you have any feedback or anything to tell, you can let us know. Thank you very much. Thank you. Okay.
With the teaser and a great demonstration of the product and the software, we would like to conclude the events for the day. Thank you for such an astounding day of learning, and we hereby request permission from our patron, Dr. Tanna sir, to conclude today's day of learning and proceed further for the gala night at the Reed Resort in Silvassa. We'll be meeting you at the resort at 8:15, and I request you to take your cabs or buses from outside the academy reception. Thank you. Sorry, sir. Yes, everyone please requested to carry their luggage to the resort. and your buses and cabs will be waiting at the reception.